Well, hi everyone, it's Pete here from the Pain Toolkit here in the UK, 2 o'clock in the morning, we're digging it. Hey, listen, welcome to the third Pain Supported Self-Management Conference that myself and Keith Belgium have organised now for 3 years. And listen, we've got another amazing group of people to present to us, or wherever you are on the planet, where it might be your afternoon, evening, or whatever. But I'm still focused on the morning. But I would say massive thank you for registering for the conference. And I'm going to introduce some people to you before I hand over to our first speaker. So, as you can see on the screen here, you've got Keith Meldrum. Hey, Keith.
Hi everyone. Thanks for joining us tonight. Like Pete said, I'm happy to be part of this. This is the third one that I've had the honor to coordinate with my good friend Pete. I'm way over in the west coast of Canada, so I'm way behind most of you. You guys are all in the future for where I am. So I'm really excited to be doing another one of these. We've got an amazing lineup. I get the honor of introducing our first speaker tonight here once we finish our introductions. But it's nice to see everybody, and thank you for joining us.
Okay, I just want to introduce a couple of guys behind the scenes who are going to be working here. So we got Grania Daniels, who's there. She gives you a little wave. She's from the UK as well. And Grania, do you want to introduce yourself? I know you're going to be working behind the scenes, taking the questions via the chat, etc.
Yeah, brilliant to be here, and thanks again for letting me be involved in this. I'm a physio by background. I work as a pain coach, sort of trying to help support people self-manage, and I'm really excited about the lineup we've got here. And I'm going to be working in the background to collate any questions or comments that people put on and present them to all of the speakers as we go along.
Thanks, Grania. And down there with the Golden Gate Bridge, by the looks of it, is Dave Oxley. He's going to be working behind the scenes, doing all the technical stuff, so that myself and Keith and Grania, we can do our bits and bobs. Dave, do you want to introduce yourself?
Yeah, I'm in the UK, so again, stupid o'clock in the middle of the night. Yeah, I'm a pain self-manager that's been around for a while and involved in the Pain Toolkit Academy. So yeah, really looking forward to the speakers tonight.
Thanks, Dave. So, what have we missed out on here, Keith? Have we got anything else before we crack on?
Well, I'll just take a moment here. We've got a few minutes while people log on. I just wanted to say, again, we appreciate everybody joining us tonight. We've got just an amazing lineup of presenters, and I wanted to say to everybody who's going to be presenting, when Pete and I reach out to them, we just get these sort of overwhelming yeses. We don't even finish saying what we want them to do, and they just say yes, they'll do it. So really excited. We've got another amazing group of people. It's a combination of people with lived experience who will be presenting, their experiences and what they've learned from their pain and how they've moved forward to live a better quality of life with their pain. They're going to share what they know. And then we've got some researchers here in Canada and in Australia who are going to be talking to us about the work they're doing. We've got a medical doctor. We've got this amazing breadth and depth of people who have come to talk to all of you today, and to Pete and I and Grania and Dave, because I learn every time about true supported self-management. So it's a real honor to have everybody with us tonight, and that includes all of you who are joining us either live or will be on the recording.
Well, thanks very much, Keith. I think so. We'll hand over to Katie. Well, I think you're going to do the introduction, Keith.
Yeah, I get to. That's okay. Don't step on my thunder. I get to introduce
Well,
Katie. No, she's near and dear to my heart, and she's a Canadian. She's in the next province over. So I've just got a little short bio here for you, Katie. I'm not going to steal your thunder, but I'm very, very pleased to have with us tonight, and starting off first presentation tonight of what is the third conference in the inaugural Pain Supported Self-Management Week. So this is big. We're making history here, and Katie's gonna start us off right. So Dr. Katie Burney, she's a clinical psychologist and an assistant professor at the University of Calgary in Alberta, Canada. She leads the Partnering for Pain program there. Dr. Burney is the Associate Scientific Director of Solutions for Kids in Pain, called SKIP, a program, an organization which I think is just brilliant. And it's a national knowledge mobilization network working to improve evidence-based children's pain management through coordination and collaboration. So we talk a lot about persistent pain and self-managing. A lot of that happens when we're talking about adults or even young adults. Dr. Burney here is going to talk to us about the brilliant work that's happening and that she's been a big part of when it comes to children. So with that, I will turn it over to Dr. Burney.
Wonderful. Thanks so much, Keith, and thanks for the invitation to be part of this today. And just before folks were joining, we were all just echoing the gratitude of actually getting to talk about kids as part of this broader conversation in self-management and how critical that will be. I'm going to share my slides. I just don't think
Let me just give you permission. It's a bit I forgot there.
all good. I think folks can see it there now, I hope.
Dave, can you remind me, am I hitting the right button?
Yep, we can see your screen now, Katie.
Brilliant. Awesome. Thanks so much, Keith. So happy to spend some time over the next half an hour talking a little bit about pain in children. So appreciate the kind introduction. I'll just start here for us in Canada. A huge opportunity, I think.
Sorry, Katie. We're just seeing your just a Zoom splash screen.
Hang on. I'd say that shouldn't happen, and should it?
It popped up first.
Hang on a second. Let me just think I might have hit the wrong button.
No,
there we go.
It's fine. Just let Katie share. Katie, if you just share again, we just need to give the focus to a different window on your laptop. That's all.
Oh, sure. Let me try one more time.
Is it the multiple one, Dave? I've just done. Yeah, that's it.
Yeah.
We're seeing Katie's slides again now.
That's my fault. Sorry.
No, that's okay.
All right.
All good. So I was just going to start by acknowledging where I am here in Canada. As Keith mentioned, I'm in the province of Alberta, which is close to the Rocky Mountains and is the traditional territories of several Indigenous peoples in this area that I wanted to take the chance to acknowledge as I get going. And if you're interested where you are, if you look at the Native Land website that's down there, you can identify the Indigenous lands where you are anywhere around the world. So why are we talking about pain in kids? Why is this something that matters? So first and foremost, I always like to start by just saying it is pervasive. So the rates of chronic pain in children are actually the same as adults. About 20% of kids will deal with some sort of chronic pain or pain lasting at least 3 months or longer before they reach adulthood. So there is a lot of continued myth that it doesn't actually occur in kids when in fact it does. The short and long-term consequences are very noted in the research literature as well as in clinical care. Very similar to adults, although it's impacting children's lives, right? So both their emotional functioning, children with chronic pain are 2 to 3 times more likely than their peers without chronic pain to be dealing with anxiety or depression or other mental health concerns. It impacts their physical functioning, of course, their family context, relationships with parents and siblings. It impacts their ability to function at school, whether that's the ability to get to school or to concentrate or be able to engage in school-related activities. It impacts their sleep and also their social well-being. I collaborate with a colleague who's just been looking at loneliness in adolescents living with chronic pain. And when we think about that time in adolescence, as kids are becoming more independent and developing their own identities, peer relationships are so key to their well-being and development into adulthood. So the fact that it's really impacting their social well-being as well is really critical. The other part that I always think is important to mention is that pain that starts in adolescence is what often starts a cascade of chronic pain, mental health issues, in some cases substance use issues, as well as socioeconomic disparities that actually last into adulthood. So some of this literature comes from population-based studies that have followed youth over time into adulthood. And even if their pain is resolving, they're at greater risk for mental health issues and things like, challenges in the workplace, academic attainment, vocational planning, and so on as they move into adulthood. So it is something if we want to try to address and tackle and think about prevention and support across the lifespan of spending some time focusing on and preventing pain in adolescence is really valuable. Of course, no surprise, it has huge direct and indirect costs. One of our federal agencies here in Canada, Health Canada, has looked at some of the economic data to identify some of that. But I know many folks around the world, in Australia and otherwise, have looked at some of the economic cost of chronic pain in adolescents as well as in the US. And we start to see these impacts in the family, right? If your child is needing to go to many appointments, it means parents can miss out on work. And other such things. So it can really become quite a family affair. And I think, similar to how we're talking about this around the world, quality pain care is a human right. This is something that all children should have access to, as well as adults, right? And so it's something we need to think about there too. But we do know that certain populations are disproportionately impacted by pain, including in childhood. This is particularly notable for children who are nonverbal, children who have various developmental disabilities, as well as other groups such as Black youth, Indigenous youth, and similar to adults, females or girls are disproportionately impacted by chronic pain in adolescence as well. You can hear me as I'm talking allude to the family context. And one of the things that we've really started to note, and this is research that's really emerged over the last 5 to 7 years, I would say, that starts to look at pain as an intergenerational issue. What we know is about 50% of children who have chronic pain have a parent who's dealing with chronic pain or has dealt with chronic pain. And children of adults with chronic pain are 1.6 times more likely to also report pain as compared to children of parents without chronic pain. So what are some of the factors here? Sure, some of it could be genetic with certain types of chronic pain conditions and so on that maybe have more genetic etiology. But as many folks would know, the causes of chronic pain, there's a myriad of factors, right? So, it can also look at other types of early environment, life experiences, other kinds of risk factors that might come into play in addition to potential genetic risk. The other thing we know is chronic pain in children significantly impacts the family environment. So parents of children with chronic pain also report dealing with mental health concerns such as anxiety, depression, general distress, more parenting role distress, and in some cases more post-traumatic stress disorder symptoms. So really the message I want to share here is pain is a family affair, right? And whether that's multiple people within the family who are dealing with pain, it certainly is having a greater impact. So it's something we need to think about when we talk about self-management, when we talk about care, to not just to consider what skills does the youth need to have in terms of their own self-management and approaches to pain, but how are we supporting the family more broadly, particularly thinking about parents and parents in managing their own pain if they have that, but also just the stress and other impact on themselves that may come from having a child with chronic pain. And I think self-management has a key role because our health systems, at least certainly not here in Canada, they're very separated, right? In terms of pediatric care or adult care. So there isn't a great place necessarily for family to get the whole care that they may need to support them to manage some of these challenges. There's a few really important milestones that have happened in the pediatric chronic pain world in the last, 5 to 7 years. Of course, similar to for all of us as we talk about chronic pain around the world, identifying the ICD-11 in the International Classifications of Disease from the World Health Organization, having chronic pain identified as its own condition has certainly also impacted the pediatric pain world as well. In 2020, the WHO worked closely with several pediatric pain experts, researchers from all around the world to put together evidence-based guidelines on the management of chronic pain in children. So this is really pivotal in terms of continuing to provide guidance internationally. In 2021, there was a commissioned Lancet Commission on pediatric pain, which really focused on summarizing the knowledge that has emerged in the field, but also what transformative action is needed to continue to improve pain in kids internationally, including how we make pain more visible, how we make pain better, how we make pain matter to all folks. And then the last thing here, which we've worked on, I had the privilege of leading with Solutions for Kids in Pain that Keith mentioned in partnership with the Health Standards Organization, was development of the world's first national health standard for pediatric pain management. This was published here in Canada in April of 2023. And it provides direction to organizational leaders and health professionals about the delivery of quality, equitable pediatric, acute, and chronic pain care in any hospital setting. So this has been really pivotal for us because it's part of the system and structure that then supports accreditation of hospitals in our publicly funded health system in Canada. So it's a really important lever within our health system to provide direction around the delivery of quality pain care. What's really cool about this document is we had folks with lived experience who were part of the working group that developed the health standard. And so that voice in person-centered pain care and the importance and equal membership of both children and their family members on the healthcare team in the delivery of quality pain care is really, really strongly emphasized in this document. And just to give you a sense of interest around the world, since it was published in April 2023, it's been downloaded more than 2,000 times from about 70 different countries. So there's clearly a lot of interest and need. And I put up the QR code. It's free to download. It's available in English and French, and I think provides good direction even for quality pain care outside of the hospital setting. So what do all these documents tell us? And as we move into talking about self-management, probably a consistent theme you'll hear through many of the talks, I'm sure, throughout the conference, they all recommend a multimodal approach to pediatric chronic pain care. So what does this mean? It means that we're talking about the integration of psychosocial strategies, physical strategies, and of course, pharmacological strategies as well. Why? I'm going to, no surprise, as Keith introduced me, I'm a psychologist. So, one of the things I want to talk about is an emphasis on psychosocial strategies, recognizing they are all important and all play a role together alongside physical and pharmacological strategies. Why I want to talk about these in particular, though, is not just because I'm a psychologist, it's for several other good reasons. One is it's a top priority. What are effective psychosocial strategies or treatments for improving pediatric chronic pain care? And it's a top priority according to youth themselves, family members, and health professionals. I led a James Lind Alliance priority setting partnership, which essentially puts the power in the hands of those with lived experience, family members, and health professionals to decide what are top priorities in a given area. It's a methodology some folks might be familiar with that's based in the UK. And this was among those top 10 priorities from hundreds and hundreds of people across the country. So we know it matters to people with lived experience to hear about this. The next piece is that we know psychological treatments have the most amount of evidence for supporting youth with chronic pain in terms of improving their functioning and so on. So this is from a review that we published a few years ago where we looked at all of the systematic reviews and clinical practice guidelines that were available for any type of treatment for pediatric chronic pain. And you can see there was about 40 different reviews and clinical practice guidelines we included, and the majority focused on the delivery of psychosocial interventions, as well as pharmacological interventions, physical, interdisciplinary, or more intensive rehabilitation programs, and then other types of interventions like diet-based and so on. So there's a lot of evidence for us to be drawing from in terms of the effectiveness of psychosocial strategies in pediatric chronic pain specifically. Of course, the other reason it's important is our thoughts and beliefs can influence the effectiveness, even of medications and other treatments for chronic pain. So folks will be very familiar with the placebo effect, for example, right? So psychosocial strategies are really an effective tool that we can harness to support our management of pain. And then lastly, if you get to this point, right, they are also really helpful because they are strategies that we can have influence over, right? That we can have, an important role in terms of how we focus on functioning and move forward in the presence of chronic pain in children and adolescents. So what's part of these and how do we talk about them? Again, consistent things to some of which you might have heard discussed in terms of adult chronic pain care, but they are typically cognitive behavioral in focus, which essentially just means they talk about our thinking habits. So as well as our feelings, as well as what I like to call valued actions or our behaviors. And in doing so, they do harness the neurophysiological mechanisms of chronic pain by addressing these strategies together that can actually impact how our nervous system is modulating pain signals in our bodies. And of course, these are all connected. How we think impacts how we feel, impacts what we do, and vice versa, which gives us many places with which our self-management actions can influence what we're doing. Of course, when we talk about feelings, and as a psychologist, I always think it's really important to validate, of course, because of the invalidation that a lot of folks with chronic pain, including adolescents, face from health professionals, from coaches, from parents, from friends. It's really important to start by validating the I'm using the same word, but validity, right, of chronic pain, that you believe that that's real. It is a thing. We know that because of how kind of the nervous system's functioning and spending time there, but also leveraging and really providing that rationale for these strategies. A lot of the strategies we talk about in this space are deep breathing, paced breathing, belly breathing, which are often tailored for kids of various ages, including some really great strategies for really young children who might be dealing with chronic disease-related pain or otherwise. Things like progressive muscle relaxation have evidence, as well as guided imagery and hypnosis, and of course, talking about sleep. What's beautiful about working with children is they have incredible imaginations. And so oftentimes being able to harness that for some of these self-management strategies can be really helpful. So anyone listening, what might this look like in reality? I've worked with youth who, we found when we think about guided imagery and what helps them in that have even been things like their favorite place is Disneyland. And we could creatively find online actually an audio recording of the Disney park, that they could kind of use to enhance their guided imagery. Not my form of relaxation, but for this young child, that was the epitome, right, of being able to engage in that. So I think, when we think about some of these self-management strategies in kids, we can really harness the joy of that time and development in their lives. The thinking strategies are also really key. And it's a really interesting age to talk about this as kids are very rapidly developing their own cognitive skills and how they think about the world over time and their place within it. Pain education, I think this is still so critical for everybody when we think about any sort of chronic pain management, but also true in children and adolescents, and being able to tailor that information in ways that they can understand and comprehend. Strategies like mindfulness have become increasingly taught actually in schools, in public schools, for us here in Canada and likely around the world. So those become continued strategies we can pull in big ways and small ways to support them as well. Oftentimes, and this is where I can take up my own beefs with other psychologists, I really shy away from the terms like positive thinking or positive thoughts. Thoughts are thoughts, right? We can't help the thoughts that we have, and often in the face of chronic disease or chronic pain where it's having a huge impact on your functioning in your life, I think it can be quite invalidating to talk about thoughts as you need to just change and think more positively. So I really like to approach this as thinking about helpful thoughts or more balanced thoughts in terms of thinking about it in that way. And also identifying thoughts are not facts, right? These things can come into our minds and we don't have to hold on to them or act in accordance with them always either. And then, of course, distraction. Distraction always has its place. And sometimes when I talk to teens or other kids about distraction and its value in terms of pain management, some go, "Oh, great. So you're going to tell my mom that it's okay that I just play video games for a long time." And you go, "Well, It's not quite what I'm saying. They do have an important place. You should be able to do it sometimes, but not in the absence of being able to fully engage in your life and do the other things that you need to do. So really, it becomes about building. And again, I'm speaking to the choir here, a toolkit of strategies, right? Of course, that you can draw from that are good for you in all different contexts. And then I mentioned I often talk about valued actions in the context of what we do. And for those who are familiar with psychosocial strategies, also very aligned with an acceptance and commitment therapy approach. This is a really cool age to talk about values in as well, especially for those teenagers as they move towards later adolescence and are thinking about young adulthood. It's often a group that have started, they're really in this identity formation time of life and figuring out who they are. And so it's really critical, actually, that we get to have conversations about who they are, who they're becoming, what defines and excites them beyond their pain experience. Because becoming too identified by their pain experience, I've seen sometimes in youth where then they start to think about their futures in very, very different ways. And focus on all the things that they can't do, that they aren't able to potentially move towards in terms of thinking about life after high school, and whatever that looks like, right? And so I think really having conversations around values helps them in that critical period of identity formation figure out who are they, what do they care about, what matters to them, that's differentiated from their parents, their peers, their teachers, their coaches, and those kinds of things. And so that becomes a way that we can focus on meaningful activities, what helps them move towards those things in small ways or big ways, to set kind of concrete, smart, functional goals that allow them to get back to the things that they need to do and that they want to do. And parents can play a huge role in this as well, right? In encouragement, in terms of supporting teens to break down things into manageable chunks, and especially around a school-based environment, if they haven't been at school and getting back to school, parents can be a really strong advocate and support alongside that to build a good return to school plan. And then I mentioned loneliness, so making sure that there's lots of social connection and opportunity for connection, even in new ways with peers, if they're not able to do the same things that they used to be able to do before pain. Oftentimes this comes up a lot in youth who are dealing with chronic pain, but who have previously really been high performance athletes. And so a lot of their social identity and connection is really tied to that sport or that activity. So they, alongside losing that functioning, they lose a lot of that social connection as well. So how to continue to support that space for them and make sure that's still there. Back to the takeaway, these things all fit together, right? There's many, many strategies here, and I've focused on the psychosocial strategies that are part of self-management for chronic pain in children. But of course, the physical and pharmacological strategies are key. And sometimes the psychosocial strategies are really integrated closely with those, like when we're dealing with fear of movement or, how that's impacting an ability to engage in physical therapy or other types of things, can be really important to build in those psychosocial strategies too. Keith, very much thank you for bringing up a national organization I have the privilege of working with called SKIP, or Solutions for Kids in Pain. It's a Canadian national network. We have many hubs across the country. We have a mandate to follow the Patients Included Ethics Charter, but go beyond that to really build in folks with lived experience throughout all of our activities. So SKIP doesn't do research, SKIP doesn't deliver care, but we're really here to bridge that gap to make sure that all the great evidence-based knowledge about children's pain is actually reaching families, is reaching policymakers, and is influencing practice and policy across the country. We do it all in partnership, like I said. So lots of infographics, webinars, podcasts, videos, tools, advocacy efforts, and so on, all done in partnership with youth and families with lived experience, and have compensation that goes alongside that, which we strongly advocate for more broadly to others inside and outside of the pain world. One of the pieces and projects that we focused a lot on speaks to opioids and pain in children. So for those of us here in North America and around the world, but here in particular, the opioid crisis has really driven a lot of the attention actually on chronic pain and the opportunity to build that. Although opioids, as it intersects with chronic pain, is a different issue in youth than it is in adults. In pediatric care, we never faced some of the same challenges in terms of prescribing of opioids or widespread prescribing of opioids in pain in children. However, so it's not widely used for chronic pain in children. However, it does play an important role when indicated. And so, in many cases, even in impacting acute pain in children, such as after major surgeries and so on, which if we don't address well, can develop into chronic pain. There's still a lot of stigma as it relates to opioid use, even when it is indicated in kids. So we spent a huge effort with a large grant from Health Canada that was really focused on guiding the effective, equitable, and safe use of opioids for acute and chronic pain management in kids. So I just put up some of the resources we have there for health professionals and also for families. We also talk about procedure pain management and then, some specific resources available, such as a guiding tool for chronic pain in adolescents in the school environment. I know I'm nearing the end here, so just want to share a couple of other great resources that folks might be interested in to follow up. Here in Canada, we have something called the Power Over Pain portal. There's also a version for adults, but I've shared here our version for youth. So it's an online self-management portal for youth with chronic pain. It links to an abundance of other articles, videos, podcasts that focus on chronic pain, mood, worry, sleep, substance use, and otherwise. Teens can also track their progress in terms of their functioning to see that self-management aspect as well. And in the background, I'm working with some colleagues, and there's going to be development of a caregiver portion. So what resources do parents need alongside this as well? So stay tuned for some of that I hope will become available in the next little while. And of course, it's all available public and free. Many of you may be familiar with this group. It was developed by Dr. Rachel Coakley at Boston Children's Hospital and Harvard in the US. It's called the Comfortability Program. It was initially developed as a psychosocial intervention delivered in hospitals and chronic pain programs around the world. And that is certainly part of it. But there's a lot of great resources for self-management available on their website as well for parents and caregivers, as well as for teens, including coping stories, guided exercises, how-to videos, supporting return to school planning, all sorts of stuff. And they do also have a version for youth living with sickle cell disease as an important population within the area of chronic pain across the lifespan, but also impacting kids. Another group you might be familiar with is the Meg Foundation. It's also in the US. They have phenomenal resources, a lot focused on procedural pain, but also some great tools for chronic pain as well. Very family friendly, very available, very appealing to children and youth. And then, of course, many of you might be familiar with Pain Bites, which is a resource that has been around for quite a while in Australia. But they also have a section for youth, which has some great videos and resources and other things as well. So nice to see that embedded alongside some of the resources available for adults. And with that, I'll finish up. Hope to keep us on time and do my job with that, and happy to answer any questions. But of course, reach out. You can reach out to me directly over email. And then I put up some contact information for Skip that I work closely with, including a monthly newsletter, and have a lot of presence. Skip has presence on social media, so you can stay up to date and connected through that as well. Thanks.
Oh, Katie, that was amazing. Thank you very much. I know we got one question from James and Grania. We'll get into that, but I'm compelled to say there was so much in that really I connected with. So this isn't about me, but I had my own experience with my pain as a youth at 16. And I just wanted to mention one of the things that you said. And I don't know if this is in other jurisdictions, but I noticed in Canada, I had my accident at 16, so I was treated as a child. It was pediatric. I was in the pediatric ICU. And that changed from I was a youth or a youth with trauma and pain And
Yeah.
then I was exited out of that and into the adult system, and it's abrupt. It's just like a lever is pulled, and you go from what was a bit more of a supportive environment to just floundering. So I would love to see that. I don't know if that happens elsewhere in the world. Are you aware of?
Yeah, it's a good question, Keith. And I've had the privilege of practicing a little bit clinically in both on the pediatric side as well as the adult side. And I always find, as someone who comes more from that pediatric lens, we often hear our adult colleagues and others say, "Oh, we baby kids too much," kind of in a pediatric system. And my perspective is, well, maybe we all need to be babied then. Maybe we all need more of that support across the lifespan. I don't think it means we give less. We should give less in the
Right,
context of healthcare for kids. I think it means we need more, right?
right. Yeah.
But certainly I think it's an area that continues to have a lot of discussion. And I know there are some, both in terms of how do we support adolescents in that transition, right, to adult care, but also how does the adult system prepare and tailor kind of supports to receive
Hmm.
young adults kind of into that system as well, when of course adult care is covering a breadth of the lifespan, right?
Hmm.
From late teens to your 90s,
Yes,
right?
yes,
Like, so
right.
there's a lot to cover in that. And I think a lot of people experience, unfortunately, still some gaps in that care. Um, and it's just something we really need to continue to emphasize and support for sure. I know, yeah, I think there are some that are trying to specialize. A couple places in Canada I know are trying to specialize more in that young adult space.
Hmm.
But of course, that doesn't mean it's accessible, right, to
Right.
everybody.
Yeah.
Yeah.
No, thanks. Brian, I'll turn it over to you. I think we got some questions in the chat.
Yeah, thank you.
Mhm.
Yeah, there are a couple. I would just say on that note of that transitional services, I think you're right. I think there are quite often that there's a very abrupt change. I know that there are at least a couple of services within the UK where they have larger pediatric pain services that do try and run some what they call transitional services. So specifically targeted to sort of 18 to 25 year age group. But yeah, it's often just such a big jump, isn't it, from that supported environment up to the adult environment. But I think you hit the nail on the head there. It actually isn't about just, well, they just need to be prepared for this world and this reality. It's actually, well, no, can we not just, should we not just try and make that reality a bit more like the other one? But so we have a question online from James, a statement with a question where he says that when he's using mindfulness for pain, he often focuses on relaxation as a target. With his granddaughters, they don't want to relax, they want joy. How do you utilize mindfulness with your young clients?
Gosh, what a great question, and what a great observation too. I mean, for me, one of the great things about mindfulness is, it's a skill, right, that we can apply to many different things. We can certainly use more structured mindfulness in terms of relaxation, but really at its core, mindfulness is being in the present moment experience, present moment in a non-judgmental way and not getting pulled into your thoughts of what's happened before or worry about what might happen in the future. And, I think that can be connected to relaxation and it can be connected to joy, many of those things. And one of that question, it reminded me actually of a mindfulness exercise that we've used before called the sweet spot. I don't know if folks are familiar with this one, but it's an opportunity to reflect and think about a small moment in your past week, something really simple, may have only been, lasted a few seconds, maybe, a minute or two, where everything in that moment was just as it needed to be. And descriptions of that, examples might be, gosh, when you take your first sip of coffee in the morning, or when you step outside and you feel the sun, the warmth of the sun on your face, or like any those things, and those are going to be different for anybody, right? But right in that moment everything felt complete. It might not have lasted long, but then there's a guided mindfulness exercise around that, and it also focuses on this idea like, gosh, our world, our experience is made up of moments, right? And the opportunity to stay present and be aware of when that moment happened, knowing that it's going to move, right? There might be something different that comes. So I guess my response to that being, there's some potentially great mindfulness exercises out there, guided or otherwise, that can be focused in joy, right? That don't just have to be focused in relaxation. So if that's what appeals and that's what hooks them in, to that, um, go with it. There's a great place within that to maybe build that skill of mindfulness, which essentially is, yeah, gives us that moment to build awareness. And I also use it to support youth to build awareness about their experience, but also develop that skill. For example, when they talk about being in the environment, when you can intentionally, mindfulness is great in the context of pain because it also builds your skill to intentionally shift your attention. And pain always seeks to grab your attention, right? Like that's what it does. That's what it's supposed to do. And so when we build that mindfulness skill to intentionally shift our attention somewhere else, it might mean that, pain, instead of being right present here, we can shift our attention to something else so that pain's just a little bit more in the background. It might still be present, it might still be there, but we're building that skill to intentionally shift our attention to something else. And that can be helpful at school. That can be helpful, at work when pain is inconveniently showing up in our lives. So that's how I often talk about it, to shift it away from this notion that sometimes youth feel it's set up that, oh, if I do this mindfulness exercise, my pain will have decreased. Like at the end, the intensity of my pain might have gone away. And then they kind of feel like they've been duped, right? Like, or it's the same with deep breathing. Like we often find a lot of times when we're introducing that it's been missold to them in the
Yeah.
past. As like, oh, if you take a few deep breaths, you won't notice your pain as much. And they go, well, that's not true. That's not my experience, right? So how we kind of shift expectations around that, and how some of these psychosocial strategies have genuinely been missold, right? And yeah, if I can take a minute to share another quick story, I have a colleague who often tells this story when we're teaching these kinds of things to youth, who had worked with a youth with real intractable migraine, had been hospitalized for several days. They'd been through all of the medication protocols and all these things, and their pain was continuing to unrelent. And they said, okay, I guess we'll bring in the psychologist. She'll teach you how to breathe. And you kind of go, really? Like, how is that a good setup, right? So we often start there and go, look, this is not what we're doing here, right? This is where that pain psychoeducation, we're going to help use some of these skills to turn down, dial down your nervous system and build these skills to be able to shift your attention to other things, to really be able to emphasize how can you get back to some of those meaningful actions, right? Your pain might still be there, but, and we can't promise it's going to go away, nor are we going to promise that some deep breaths will get you there, or mindfulness exercises. But here's how some of these skills can fit well into supporting you, into the life that you want to be living. Hope that helps some.
Yeah, that was useful. Thank you. I had one. Well, I had a couple of things, but I think we might only have time for one of them. But I thought it was really lovely right at the start where you when in that work that you were doing, the priority setting alliance, trying to figure out what was going on. That for that 32% felt that that adolescents really felt psychological strategies were really important, and that the evidence was there for it. And I just felt like that feels to me, as somebody who's worked in healthcare for 30 odd years, that's definitely a shift, because certainly in older adult patient populations that we see, it's really almost can be quite challenging to get them to see the importance of psychological strategies, whether that's barriers that they've learned over their lifetime or the fact that it just wasn't being talked about. Do you think it's because younger people now are that things are much more openly talked about, so they're much more aware of the impact of mental health? Or so is it a societal thing like that, or what makes them more open to psychological strategies?
That's a great question. And I think there's still a bit of both. I think, when we did our national survey that kind of asked very open-endedly, what are the top priorities you have for pediatric chronic pain research and care? The most common response that we got was to address kind of the invalidation that they've experienced from health professionals, coaches, others, peers, friends, parents, siblings, grandparents, all of the above. So I think there's still a lot of dismissal. And I think some of that comes from a lot of things. Some of it comes from the belief that chronic pain in kids is not a real thing, that it doesn't actually exist. Of course, you can't have chronic pain, you're 13 years old kind of thing, right? So I think there's that uphill battle. I think there's some similar issues that adolescents face that are also true for adults. So because it coincides, with greater risk of mental health issues like anxiety and depression, and because it's more common in girls and females, there's a piece of, oh, again, I'm being really flippant in this. This is not what I believe, but the message we get from others that they receive is, oh, you're an anxious teenage girl.
Yeah.
And because pain's invisible, because they are also anxious, but hey, if you're living with chronic pain every day, it makes sense. You might be experiencing some of that worry and stuff too. But I think, that's similar to some of what we might hear in adults. And I think that's also true with kids. So I think there's a little bit of resistance at times, very understandable to psychosocial strategies, because it's then saying, oh, you're sending me, I need to see psychology because it's all in my head. Right. So I think there's still a really, really strong need with adolescents to talk about the psychoeducation around pain and the neuroscience of pain to help provide that reassurance that your pain's real. I believe your pain is real. That is not why you're sitting here, right? And here's why psychological strategies can help. So I think that still exists and is still a really, really important part of how we work. And I agree with you. There is a lot of change in how mental health issues are being talked about and the stigma around that, and how it's being talked about at school. It was interesting for me, and, I've been working in the area of pediatric chronic pain for about 15 years, and how much it's changed even in the teenagers we work with to hear about mindfulness being taught at school. Right? Not in relation to pain per se or anything like that, but it's really shifted. And then you say, we're going to talk about mindfulness. And they go, oh, I know what that is. Right? I've done that. Or they told us about this app at school. And you go, great. Then your conversation is more about, here's how you can adapt that and use that around your chronic pain instead of feeling like you're starting to talk about a whole new thing. Right? And sometimes they've built up some of their language around uh, being able to talk about anxiety and depression and some of what they might be experiencing. So both and, I think in response to your question. Yeah.
That's lovely. Thank you. I'm
Thank
going to hand back to Keith.
Great. Katie, that was amazing. Thanks very much. What a wonderful way to start off the conference this year. And like I said, just a real honor as we celebrate Pain Supported Self-Management Week. So thank you very much for being with us tonight. That was amazing.
Of course. Wonderful. Thanks so much. Enjoy the rest of the conference.
Okay. Thanks, Katie.
Bye.
Bye. Pete, did you want to, we've got
Yeah, I'm going to
Tom.
go straight on to Tom. I know you're there. Ready? I know. I'm just looking at Amanda with who's got the dog there, is watching the conference in the beautiful sunrise well, in the daytime there. She's got to be in Australia. Anyway, listen, we're going to roll straight on to Tom. Good evening to you, Tom.
Hello.
Hello there. So, thanks very much for coming on the conference, being a presenter. We've known each other now for only, and sadly, I think we did an interview once, but mainly through social media and stuff like that. Massive admirer of what you're doing, though, Tom. You seem to be carrying a lot of the load over there in the United States with what you do. So, massive shout out to you. Let me give you a nice little bit of intro. So, Tom lives in or near Des Moines. Am I pronouncing that right?
I'm sorry.
You live in Des Moines?
I live in Des Moines, Iowa.
Des
Yes.
Moines, in Iowa. Okay. And Tom is a person who lives with pain. He's an educator and an advocate. He is a founder of the Chronic Pain Champions, which is an information resource and support hub for many people living with persistent pain, non-malignant pain, with their families and friends and healthcare professionals. So, Tom, if you want to launch your slides.
Yeah, I'm going to bring those up. One moment.
Here you go.
All right. Very good. Well, thank you very much, Pete and Keith, for inviting me to speak at the conference. Number one, I'm honored. And I'm flattered by the warm introduction, Pete. And yes, we did. We have met a while back, and you interviewed me a while back, many years
Yeah.
ago. So yeah, that was early in my years as being a pain advocate and educator. So I appreciate that. What I want to talk about tonight is three things that shaped my personal recovery that I want people living with chronic pain and those who support them to know. But real quick, let me tell you a little bit about me. My journey with chronic pain started in 2009 after nerve damage from a emergency surgery. That pain multiplied after a 2013 fall, left me with a 24/7 severe headache, a headache that didn't go away for 7 years. And shortly after that headache, I started feeling other sensations, just random sensations throughout my body, widespread pain. I started feeling numbness and tingling in my toes and feet and in my hands. I started hearing a ringing in one of my ears. I became anxious. I became highly depressed. Just like a lot of people that have chronic pain, I was struggling. Where I found relief was at the Mayo Clinic Pain Rehabilitation Center. And like what you've attended, Pete, with your program, the Mayo Clinic is an interdisciplinary program in the United States. And I spent 3 weeks at the program. I actually attended the program twice, but it's a 3-week program. Psychologists, a team of psychologists, physicians, pharmacists, occupational therapists, physical therapists, nutritionists. They team together to teach people about what's happening to them and then empower them with strategies they can use to manage the pain and to live life. Katie kind of mentioned, she talked about family support. And one of the key elements of the Mayo Clinic program was 2 days of the program was devoted to family. So we got to do that. I have links to pain rehabilitation programs around the globe on my website. So if you're interested in looking to see if there's any near you, I've assembled some. And if you have any that I'm missing, please share those with me via my contact form on the website, because I'd be sure to add those. Since 2019, I've become a pain advocate and educator. I shifted from being a pain patient to being someone who could help others living with pain. As a result, I no longer use medicines at all for my pain. No biomedical treatments, no passive biomedical treatments for my pain. No medicines, no supplements, no injections, nothing. And I've just been able to self-manage the pain. Do I still feel pain? Sure I do. But most of the time the pain is not even noticeable. And when it is noticeable, it just, for me, drifts into the background. It's more noticeable if I focus on it and I start to worry about it and I draw attention to it. So I just don't do those things. So here, what are the three things? Things that help me that I think can help other people too. Number one is understanding pain. I didn't know really what pain was until I got to the Mayo Clinic program. And of course, as we all know, pain is a complex biopsychosocial experience with biological, psychological, and social contributors to it. Things like thoughts and beliefs, past trauma, biological things happening in your body, your lifestyle, emotions and feelings, your social situation, your expectations about pain, your memories of pain, and any stress in your life. All those things affect the pain experience. And I just thought pain was a sensation. So come to surprise to me that I can affect some of these things that I can change. I also learned at the Mayo program the difference between acute pain and chronic pain. I never knew about chronic pain when I first attended the program. No one ever told me I had chronic pain. I just thought I was in pain. And as we all know, that acute pain is a normal response to injury or illness, and it heals, typically within 3 months. Well, chronic pain is an abnormal response that can continue to happen even after an injury heals. And one of the things I like to do, I like using visuals and when I talk and share. And one of these is a visual of a house. And if you can imagine your body as a house and pain as the alarm system. If your door of your house is broken, your alarm system's going to go off, letting you know there's a problem. But once you repair the door, the alarm system resets and you don't have pain. Chronic pain happens when the door is fixed, but the alarm keeps going off. It's a sensitivity issue. So you don't need to call the police, you need to call the alarm company. One other thing that really impressed upon me that helped me in my journey was understanding that hurt doesn't always mean harm. We can feel pain, but have little or no damage, as in the case of a paper cut. Think about it. Very little damage, but boy, do those suckers hurt, right? And what about the guy that has stepped on a nail and the nail went through his boot, the construction worker? He went to the ER screaming in pain, but yet at the ER, they gave him medicines. They took the nail, removed his boot, only to find that the nail passed harmlessly between his toes. Very little damage, but he sure was in pain. Then also, we can have signs of damage, but not feel pain. There's been MRI studies that show many people that are asymptomatic that have signs of degeneration. And I just put a few of those statistics right here on this slide from research by Brzezinski et al. So those things are telling me that hurt doesn't always mean harm. I don't have to worry about the pain. I don't focus on it. I don't worry about it. It doesn't scare me. I'm not afraid of it. Second thing that was instrumental in my own recovery that I think is helpful to other people is accepting the pain. It's often the struggle with pain that's worse than the pain itself. I know that was for me. Your life changes. Your relationships change. You may not be able to work. You may become anxious. You may become depressed. So that struggle is very real. Picture a raging river with very swift currents. Now try swimming up that river against that current. It's futile. Fighting the pain is futile. Swimming upriver is futile. It's easier if you go with the flow of the water and break free. So what does pain acceptance really mean? To me, pain acceptance means coming to terms with the pain as my new normal. Willingness to experience the pain without judgment, without worry, without fear, without focus. Not fighting the pain. Just like that river, it's a battle, uphill battle, just drawing more focus to the pain. And then getting back to life, making your life bigger than the pain. What acceptance isn't? It isn't liking the pain. It's not tolerating it. It's not giving up hope. And it's not resigning yourself to a life of misery. It means you've found a path forward. Michael J. Fox may have said it best when he said acceptance doesn't mean resignation. It means understanding that something is what it is, and there's got to be a way through it. I find it telling if you go out to the Mayo Clinic Pain Rehabilitation website on the internet, this is their overview. In that overview, there's no mention about reducing pain. There's no mention of eliminating pain. The only mention of pain is reducing the use of pain medications and other medications. Otherwise, it's talking about restoring physical activities and improving quality of life. I found relief by quit focusing on the pain, trying to fight it, and focusing on the need to reduce it or eliminate it. The third thing that I found helpful, and this is something that I know everyone's going to talk about tonight or during the conference, is taking active control with self-management. It's by taking that active control is how it empowers you to make changes. You're taking responsibility for actively self-managing the pain. I love this metaphor. I first heard it when I went to the Mayo Clinic program. Imagine you're in a car with the pain that you're feeling. Where is the pain? Where are you in the car? Is the pain driving the car? Or are you driving the car? Is the pain dictating what your life looks like? Is the pain dictating where you go and what you do? I chose to get in the driver's seat and put pain in the back seat. In fact, I probably put it in the trunk. Even better yet, put it in the trunk. Sadly, our modern healthcare system often fails people living with chronic pain. It hasn't caught up with the latest pain science, chronic pain rehabilitation, and active self-management. As James Stark said, who's actually on this conference with us, he said the perspective that we have in medicine is always illness-based or injury-based. We do not have a healthcare system. We have an illness care system. I call it the chronic pain merry-go-round, and it can be hard to jump off of. A merry-go-round where you're seeing different providers, having different tests, getting different treatments, all to find a cause and cure for the pain. But it seems like the more you try, the more you hurt. And every provider in their own best interest is trying to help you. But the more you try, the more you hurt. I propose switching from a passive, find it, fix it, relief management mentality to an active rehabilitation and self-management mentality. So switch from passive to active. Passive management is something done to the patient with no active involvement by the patient. It's things like medicine. It's things like surgery. It's things like, and I'll show you a list here on the next slide. And it also can include things that people do to avoid or escape pain. These are all things done focusing on immediate pain relief. And they can create a sense of dependence, even helplessness by that person living with chronic pain. They become dependent upon the provider instead of themselves. Passive management strategies include medications, supplements, TENS devices, nerve blocks, spinal cord stimulators, radiofrequency ablation, surgery, manipulation, massage. The list is here, and there's probably more to it. Active self-management is something done by the person. It focuses on improving function despite the pain, and it creates a sense of empowerment that the person can change their pain experience. and not be reliant on someone else to find the cause and to fix them. And many of the active stress management strategies I have on this slide are some of the things that Katie mentioned. Pain education, psychosocial strategies, cognitive behavioral therapy, distraction. All these kind of things are things that we can do to change the pain experience ourselves. And we're not relying on anyone else to do it for us. It's my contention and contention of many others, according to research, that as pain moves from acute to chronic, the shift should focus from passive management to active self-management, with passive strategies used only to allow the person to participate in an active self-management program, something that would allow them to move, something that would allow them to do those active self-management strategies. If you like what I'm talking about tonight, kind of get it, you like it, check out my resource center that we talked about, chronicpainchampions.com. On my resource center, I've gathered what I call are the pain truths. I've built a pain quiz to test people's knowledge of pain. I wrote a free ebook that's available to download. You don't even have to provide your email. I have a Facebook support group with about 3,600 members worldwide. I have a $19 pain course that's a 5-hour educational program that discusses what I talked about today, plus a lot more. I have published articles that I've written that have been published and links to other educational articles divided by topic. I have links to self-management skills, things that you can use to actively self-manage the pain. I have links to resources like books and rehabilitation programs, etc. There's one thing I want to leave, one message I guess I could leave tonight, and that there is hope. Pain can change. I know it because the pain has changed dramatically for me. It's possible to champion chronic pain and break free. And that's the end of my presentation.
Thanks, thanks, Tom. Thanks very much for your presentation, and it's like listening to myself, really, but because you're singing from the same hymn sheet that I do, and as I say, pain. I don't know. I think where these pain management programs have all sort of collated, I suppose, together with each other over the years. But I like the very strong messages that that you give out there, and it's like what the work that you're doing over there with the courses and stuff like that is doing a parallel with what we do here in the UK with the pain toolkit, etc. And
It's a team effort, Pete.
I know, mate.
It's a team effort.
Yeah, listen, I'm all with you there. It's not enough. Should be more of us, that we perhaps need to get a jelly mold out, and because I mean, I'm getting older now, so I'm not about surfing out. I'm surfing in now. So, but we
I'm
need
no spring chicken.
we need more Toms, and because I get a lot of emails from the US, Tom, and they're struggling, and I'll signpost them your way because they're looking for resources in their neck of the woods, and I don't think they realise they contacted me here in the UK, but very, very strong messages, and just keep up the good work. Has anybody got any questions for Tom at all?
I've always got a question.
Oh,
Sorry. Yeah, I just can't stop. Tom, it was really nice to finally meet you almost in person.
Almost.
Almost, yeah. Like Pete, great talk. A lot of what you said there really resonated with me. I took a lot longer to come to some of the places you did took me, but all roads hopefully lead to Rome. One of the questions I just had for you is, I really like your talk about sort of the difference between active and passive sort of modalities or treatments. Um, and I totally agree that you get to a point where you have to shift into we have to do for ourselves, right? So truly self-management. I just want to know if you had any thoughts on, are there times you had your two slides and you talked about the differences, but do you feel in the context of supported self-management, there are times when it's still appropriate to sort of dip back into some of those other things like your massage therapist or whatever for just a little boost to help you if you're in a low spot or to get you back on track? What are your thoughts?
Sure, exactly.
Yeah.
The passive management should be used to help facilitate an active self-management program.
I like that.
So
Yeah.
those are
Yeah.
that's I mean, so if you need something to allow you to move, to allow you to go out to lunch with your friends, to go for a walk, to go fishing, to do those things that we talk about with self-management in terms of things that are bring joy and meaning into your life, whatever it may be, then yeah, then those passive modalities make sense, or passive treatments make sense. I think when it comes to supported that with the healthcare teams, I think what they need to do is stop trying to find and fix, and become more of a coach,
Mhm.
become more of a coach, and and help that person with goal setting, help that person with these skills developments, provide them links to resources like Pete's website and his guide, my website, to the resources that Katie shared, and I'm sure other speakers will share. There's so much information out there, and we just need to be able to share that information. But that shift needs to focus from being a fixer to a coach.
Oh, I'm right there with you. I talk about we got to move healthcare away from the fixer to a supporter. So, just you just feed right into my bias. So great. Great talk. Rania?
Yeah, so I have a couple of things that I wanted to say. First of all, I really love a lot of your visual analogies that you use, and Pete uses a lot of visual analogies in the toolkit as well. And I think they often are things that we as healthcare providers sometimes forget to. We can get quite absorbed in words and our use of language, and we want to describe things with a lot of words. And sometimes a picture truly does paint 1,000 words and can actually create a lot of mindset shift. So there's some really good analogies there, which I really loved. And just from my own personal work, what you spoke to about there, the kind of done to and done by sort of thing, that took me back to a pain program I started when I started doing our pain management program 20 years ago. And I used to talk about things that were we wanted to focus on things that were under people's internal control, stuff that you as a person could control, and minimize in their self-management the stuff that was outside of their control. So we talked about, you can't control if your massage therapist goes off on holiday or goes off sick for 6 months. If you're relying on them to be your way of getting away from your pain, and you don't have the things that you can internally control, that balance isn't right. And I think it's right. It's about getting the balance between using sometimes things that are external to you, but focusing on stuff that is internal. And so it's really nice to see that language coming back in again. I think the question I had almost was for all three of you, but I'd like for you, Pete and Keith, and it comes back to me more and more as a healthcare professional, is when do we need as healthcare professionals to start really using that language of supported self-management? At what point during that acute pain journey, when we are trying to find and fix and identify and see what we can get rid of, where in that transition period would it be most useful for healthcare professionals to start talking about needing to bring back people's own control? I think a lot of healthcare professionals struggle to know when to move from the find it, fix it to the other bit.
Can I start, Keith or Pete? Can I answer that?
Mm.
For me, it's right at the very beginning.
Yeah.
Right at the very beginning of the pain. There's all these things, these self-management skills that people can do immediately to change the pain experience, whether it be acute or chronic.
Yeah.
So those things work immediately. And in fact, I'm working on with a surgical project team of medical professionals to talk about how to improve surgical pain treatment. And one of the things right away is start talking about self-management right after surgery, because those things can be done. You can do some deep breathing. That will help to, I'm just going to throw out deep breathing. One of those things you can do immediately. I think for me, the shift comes when do you stop finding and fixing? That's a hard part. I can't say 2 months, 3 months, 5 months, 6 months, because we're all different. Everyone's pain journey is different. Everyone's experience is different. But I think in general, if you use that 3-month rule, if you've ruled out everything that can be the cause of the pain and treatment hasn't been successful at reducing the pain, resolving the pain, then self-management needs to be more focused at that point.
I'll just quickly jump in there and again, I mean, just got to echo what Tom said. My own personal experience. I mean, I think my acute to chronic was while I was still in the ICU. I just had no path out, and I say that because after the first surgery, which was like 7+ hours, the surgeon said to my parents, "He's going to live, but he's going to have problems later." That's the point where they should have said, "And when those problems come up, here are the things that we can do," because it might not involve a scalpel.
Mhm.
But that didn't happen. So it's getting in there, like Tom said, started early. It's every patient's different, every person's different, sorry, like Tom said. But I think as a clinician, you start to get that sense of this isn't a fixing situation, we're into a supporting situation. Let's get that skill set going soon.
Yeah.
Yeah, I agree with you, Tom. It needs to start from the get-go, really, and it's not just. I mean, we're three self-managers saying it should be, but even I noticed last year on the International Association of Study of Pain website. I mean, they're talking about self-management now, and they're saying that self-management actually needs to start even before primary care. So I'm pleased they're catching up with us. But yeah. Anyway, thanks very much, Tom, and thanks very much for your fantastic. I just want to say again for all the hard work you do, because Keith, myself, and Keith, and others, self-managers here, we'll all do our bit. But you're, as I think Keith would use the phrase, you're doing a lot of the heavy lifting over there in the States, So massive shout out to you, dude. You're doing. Keep up,
Thank you
yeah.
very much.
Just look after yourself. Don't, as I say, look after yourself because we need you.
Yeah,
Yeah, thanks
it's
very much,
definitely a
Tom.
team effort. So thank you.
It is, man. Yeah, yeah. And we're all quarterbacks as well, but anyway,
Right. It was
how's the Hawks? Is it the Hawks you follow, Tom?
What's that?
What's your American football team you follow? The Hawks, is it?
Iowa Hawkeyes. Yes.
Oh, all guys. Yeah. Okay. Yeah.
Iowa Hawkeyes. Yeah.
Okay.
Yeah. Yeah. It's funny. You mentioned that, Pete. Um, I'm not Tom Bowen, amputation of neuroma stump. I'm not Tom Bowen, neuropathy. I'm not Tom Bowen, fibromyalgia. I'm not Tom Bowen, anxiety disorder. I'm not Tom Bowen, tinnitus. I'm not Tom Bowen, major depressive disorder. I'm Tom Bowen, husband, father, dog father, Iowa Hawkeye fan, and professional clown.
There you go. That was awesome, Tom. Thanks so much. What a
Cheers,
great
Tom.
talk. Very
Thank
excellent.
you.
Thanks for joining us.
Okay, I'm hand over to you now, Keith, to
Yeah,
introduce.
I see we got our next presenter up. We're going to take, I think, a couple of minutes here just to give folks online ourselves just a little bit of a stretch break. So we'll take about 2 minutes. Jerry Durham is going to join us next. So let's just take 2 minutes here, folks, and we'll come back. I will introduce Jerry, and we're going to turn it over to him, and he's going to wow us with his brilliance. So, so 2 minutes, folks, and we're back online. Thanks again, Tom.
Cheers, Tom. You want to get your slides ready, Jerry?
Yeah, I'm going to I like to share just the portion of the screen, so I'm just making sure I can get to that. So everything's pulled up.
Okay.
So I'm ready to go. By the way, see, you got to love American sports. So Tom's an Iowa Hawkeyes fan, which is a college football team, and one of their best players plays for my favorite professional team. So George Kittle is our one of the receivers. So there's right, it's a small world. Sounds like I'm going to be a good follow-up to Tom's presentation.
Yeah.
Or yeah, so that'd be great.
What's your professional team? Remind me again. Is it the 49ers, your team?
Yeah.
Yeah.
Yeah. And they're at home watching the Super Bowl this weekend. So there you
Yeah.
go. Mhm.
I used to
It's a
like
tough one. It's,
I used to
these
like
aren't our rivals, but I can't, I have it, I find it hard. I had to choose the team I wanted to lose least, right?
well, I watched them back in I sort of started watching American football back in the early 80s, and my player then was Jerry Rice, and
You got it, man. He's still, so many of his records, Pete, still hold up. They'll never
yeah,
be broken. The numbers he put
yeah.
up, right? Yeah.
Who's the and the quarterback was I know the second one favorite. They followed up from previous to Steve something. Uh,
So Steve Young was that second one.
that's it, yeah, it's Steve Young. And who's
Yes.
the first one before them was
Joe
before
Montana.
Joe Montana. Yeah, can I forget Joe?
That was a duo. That was like the two really stars,
Yeah,
right? One was playing and the other waiting to play. And
I
he could
like
have started anywhere else. We're so lucky he stayed.
out of two. I like Joe. He was good.
Yep.
I think he's a presenter now, is he? I think is he? That's
Yeah. And by the way, I saw him in New York. I was in New York a couple months ago walking around. I'm like, Joe Montana. Oh, yeah. You had to see me. I was like, it was kind of busy. He was busy. So I'm not that guy who'll run up,
no,
but I
no,
couldn't
yeah.
believe it. Yeah. I just saw him. I was like, because he was with his family and stuff. But I've also seen him in San Francisco because he lived in a building at a real busy intersection. San Francisco is really tight. And every once in a while, I'd be sitting at the light and you'd see him walk out. I mean, huge building, and you'd see him walk out of the building. But yeah, it was crazy. Yeah.
I think we're good to go, Pete. What do you think, man?
Okay,
All
enough of the
right.
football business.
All right. Okay. So welcome back, everybody. I have the honor of introducing our next speaker. And I had the privilege of, it was a privilege to meet Jerry. It was a few years ago at one of the San Diego Pain Summits. So it's always nice to meet the people you know from social media in person. So very quickly here. So Jerry is he's a physical therapist. He lives in Philadelphia, Pennsylvania, in the United States. And he is the CEO of the Client Experience. And in that role, he educates and guides clinic owners to better understand their patient or their client's journeys. And I know because I kind of snoop Jerry and I follow him along on social media that in his work, he's always focused on and he's promoting in his business part of his work with his clients about it's the person or I don't like to use the word patient, but it's the patient or the person's first. That's the philosophy he follows and the importance of respecting their journey. So I have much respect to Jerry. I'm glad you're here with us tonight. And my friend, we turn it over to you.
Sure. Thank you. Real quick before I pull up the slides, I really want to thank Pete and Keith. And it is, I mean, I've got a podcast by the name, and it is the mantra. And someday, if anybody wants to hear, I'll tell you when the tipping point really hit in my journey was when I went patient success leads to business success. So I come from, I'm a provider, and, as far as I know, everybody in the world, even in no matter how healthcare is paid for, people like to get paid for the work they do, right? And we know whether it's funding, whether it's private, whether it's public, right? What do we talk about almost every time we get on the calls, Pete, is funding and less funding and fighting for funding. And it's no different where we are in the world. So I just want everybody to know that regardless, right, if we do what's best for the people we serve, then that financial part will follow. And so that's my mantra. That's my motto. That's the name of my podcast. And it proves out really well. It proved out well for my business and the people I work with. So I'm going to share my screen and we'll get kicking. Hey, Tom, you stepped away, but I'm a I'm a lifelong 49er fan, so thank you for George Kittle. Yeah. All right, let me get this going here. Oh, bingo. Can you guys see that?
Yep.
Cool. That's my, by the way, that's my brand new headshot. You guys are all seeing it for the first time. So, I think my beard was even a little darker then. It's pretty scary. I still have a beard right now. You just can't see it because it's so gray. So again, my name's Jerry Durham. I've been a physio. I literally have lost track. 33, 34 years. Worked in hospital setting, worked in outpatient setting, and then had my own business. It was a musculoskeletal type outpatient business in San Francisco with multiple sites. And then what I found my love was realizing this power of the team and how well my business served and our the people we serve. I'm going to use the term patients in the presentation, but know that I usually refer to people who are patients or people who could be our patients. So I go back and forth, but I am going to use the term patient in the talk just to keep it consistent. And in case anybody comes in after, they can follow. I found that involving the team in this service and not just the providers, and remember I come from the provider side, was that when we really got outside of what the provider was doing with the patient, that we could actually improve outcomes. And by doing that, we could better serve the people and the business would do better. I mean, it was that freaking simple. And it's been a long journey. So here I am. And I want to again thanks Pete and Keith for inviting me to be here because the people we serve, we don't talk to, I'm just going to say patients right now. We don't talk to patients enough, right? They're not called to the table. Oh, we're going to fix healthcare. I'm like, where are the people we serve? Looks like a bunch of people from the inside. Nothing's going to get solved today. So I'm very grateful for Pete and Keith for asking me to come into this. All right, here. What's best for the patient is best for business. I want to give you my three main principles I'm going to work off of for this talk. So what's best for the patient is best for business. And I tell my clients or people in healthcare, if you're at a standstill and you don't know what's going on, there's something wrong with your business or there's something wrong with the journey the patients are on, take a step back and start to ask yourself, are we doing what's best for this person we're serving? And if so, that will lead you to the solution. The other principle I lead from, this has really come into play probably the last 2 or 3 years. I picked up a really good book, a business book that talked about, patients' journeys. And we talk about all the time, and we don't respect this in healthcare. I'll talk pretty poorly of healthcare today, by the way. We don't respect this very well in healthcare. And we don't respect that the person on the phone right there who's saying, I need your help for low back pain, I need your help for knee pain, is on a journey. They didn't wake up with it. They didn't get it the moment they called you. They're on a journey, and it's our job twofold to understand where they are in their own journey, but then to understand how their journey within our practice, our business, our system is for them and how that's going to work for them. So this is really a two-part thing that the people, because by the way, they're not patients when they call your practice. This is another thing I hated. Oh, we got a new patient scheduled. I'm like, how could they be a patient? They're not even here. Can we just call them by their name? Can we call them a person? Yeah, all this stuff. I mean, it was a long journey. I didn't wake up one day and do this, but this person calling your office is on a journey, and we must respect that every step of their journey with us. So this is a new one that I'm bringing forward, and I think is really important and will help with some of the work I'm trying to achieve. And then the last one is your business is an ecosystem. And this applies to this whole mindset of these steps all interact. So when they call your office, when they get the paperwork, when they get an email from you, all these steps are connected and part of their journey now in your practice, in your business. And we must understand these steps. And from the concept of understanding these steps, we must understand that they are all interconnected. And I trace back the original, I believe the original source of this story is Bishop Desmond Tutu, so I'm going to give him credit. And this is this whole idea of there's a man standing on the side of a riverbank and a baby comes floating by in the river. He jumps out in the river, saves the baby. Another one comes by, jumps back out. All of a sudden, two babies come by and he's calling help. And all of a sudden, when you got this mass of people jumping in the water to save babies that are floating down the river, one man walks by and they yell at him, "Hey, come help us." And he says no. And they said, "Why not?" He goes, "I'm going to go upstream and see where the babies are falling into the water." Right. And this is that idea of we try to solve problems. And I'll give you the exact example in healthcare. All we do all the time is try to get someone connected with a provider. They call the office, it's get them on the schedule, right? Okay, Pete, you're scheduled for 2 months out at 10:30 on Friday. Pete has to take time off from work. Pete has to invest time to drive there. Maybe he has to take a bus, all these things. So Pete can show up for a 15-minute visit so we can go, oh, here, take these pills, right? So this whole idea of this journey and the ecosystem, and I'll speak a little more to this in these examples, but these are all the things and the time and the energy I spend thinking about is how do I make a better journey by doing things better upstream, right? And if some of you know me, you know my work with the front desk team, and you'll hear more about this. So the three principles: what's best for the patient is best for business. The patient that's calling, the patient who's asking for help right now, is on their own journey, and they're asking to come into your business and they want you to take that journey with them. And then the third thing is your business is an ecosystem. And I'll give you guys more examples of these, so we'll build on this. So I like to kind of tie things back together. So I said, right, patients first. So if patient success leads to business success, and I already gave the examples, every time I have a business problem or a problem with a customer, client, patient, I need to look at them, their journey, their problems, what's going on in this, instead of looking at the business side of it, right? And some examples of this are like cancels. I deal, right? We all know this in all systems, right? People canceling, they make an appointment, they cancel, right? Well, that's not good. If you're working with someone and you're making progress and they constantly have to cancel or they no-show, right? It's not good for their journey to the result they desire. And it's also not good for the business side. You're staffing, right? And then we start talking about all the financial stuff. But I say we got to take a step back and go, instead of focusing on the cancel, why isn't the patient here today? So it's this whole mindset of focusing on that person we serve at all moments and all times. The other thing I'm going to go on with you guys, obviously because of my title, is this whole idea of patient and business success. And when I say patient success, I don't just mean their outcome, right? Did Keith, right? Let's say Keith is coming to a clinic in the States and Keith has a copay, right? It's my responsibility to get him the right amount, right? So patient success is Keith knows his time investment, his financial investment. All these things have to happen along his journey with my practice for me to consider it successful. And we all know, right? We turn to people, hey, I hurt my ankle. Hey, I hurt my shoulder. Hey, I have a pain problem. Will you refer a doctor to me? And a lot of times people go, well, I saw someone and they helped me, but then they give you the bad story and they go, but I don't know if you want to go see them. So if it is just about getting people better, right, then those would be the busiest doctors, and they're not. So this idea that, again, we got to check a lot of boxes in a patient's journey within our business to make sure success is created. If we do that, we have business success. And this is going to take everybody on the team. Because the example I gave in the States, if I'm going to give Keith a cost and a price, I have to have team members who are going to be doing that work, right? And are going to be responsible and have accountability to Keith and the business to make sure we get accurate information to Keith. So this is that team effort I want to talk about and really get outside of the provider space with this talk. We can talk about the journey, and we can talk about how every step before facilitates the next step, right? That's that business as an ecosystem. So if Keith arrives on his first visit day, excuse me, and I want to break this down, this patient success and the business as an ecosystem coming together. If Keith arrives on his first day and he hasn't met his provider yet, but everything that's been promised and told of him should happen has happened, and we talk to Keith, right, using his name, and Keith knows his provider by name, and Keith knows why he has to fill out the paperwork. Keith knew he didn't need to arrive early if he filled out the paperwork on time, but he also knows we run on time. All these small things, I call it the summation effect. All these things start to impact Keith saying, I made the right decision. I'm in the right place. And right. And this is that whole therapeutic alliance thing, and this term alliance, trust building, things like that. So if I can build Keith's trust before he even arrives, that is going to facilitate a better relationship, a better alliance with the provider he's going to see. So even though I'm not going to talk about the provider very much, every step of this journey helps to facilitate the next one. So we're always setting up the provider for success during this journey. And we're setting at the same time, we're setting the patient up for success. So again, it's got to be a team effort, because before Keith arrives, there's no provider involved most of the time. Maybe might get on the phone with them, might do something short, but it's that front desk team, it's the billing team, it's the admin team that's going to be involved, that is setting Keith's up for success with the provider by building trust, by making promises they keep. So that's this team effort that it has to go into that. I had to throw this in. My name, if you would have told me when I started PT that my name would be on a research paper, there's no way I would have told you a lot of other things would have happened. But I was really excited. And this paper popped up. I didn't know where to really put this. Maybe I should have put it at the beginning, but this is a paper that was published that I was asked to help with in 24. David Poulter, Maxi Micek, Jerry Durham. Alvisa, I never met. She was on the paper. I don't really know how these things get published. All I know is I had a great time. And Giacomo was the one who asked me to come in on this paper. And this idea, this paper, Don't Be a Nocebo, Why Healthcare Organizations Should Value Patients' Expectations. This article, we put out an opinion paper saying there needs to be more research on how a team approach and how team management and the words we use and the expectations we set, how they actually play a role in patient success. So everything I just shared with you, I've been working on my whole life. And then finally, I got my name on a paper with people smarter than me and really good at this stuff. And by the way, I had read Maxi's research and I loved it. So I'm on this paper with people that I used to reach out to and say, hey, I want your help. I need better understanding of this. So we actually have put a paper together challenging people. And what's cool about this too is people from all over the world on this, from 3 or 4 different countries here. And it's this idea of the team. I call it team alliance, by the way. So this term therapeutic alliance talks about the relationship that a provider builds with the patient. But I came out of my business saying I stopped using the word therapeutic alliance because it put all the emphasis on the provider. And I was like, but relationships can be make or break by your front desk team, by your billing team. So I said, there is a team alliance. And this is that word I was trying to get to and would call Maxi about and contact Giacomo. And David and I have had multiple conversations online about all of this, building trust and things like that. So I actually got my name on a paper to say, look, the way we talk to patients throughout their journey with us is going to have a significant impact on their outcomes. And I think I heard a little bit of that when I came into the end of Tom's talk, talking about some of this. So I think this all fits really well together. So what I want to do is go a little deeper here and tell you, so if someone's a provider watching this, where I'm going to go from here, there's benefit to you. Yet as a patient, I want people to understand the journey they should expect and challenge the system and challenge the practices and challenge their providers to be held accountable to deliver a better journey, a better experience for you. And maybe if it's a patient watching this and thinking about self-management is maybe, right, what I want a person who's potentially going to be a patient or is a patient calling a clinic to be able to ask better questions on the front end. And if I pick up the phone to schedule you with a physio for a pain visit, I want you to be able to go, well, Jerry, right? I'm the front desk person, right? Do you teach self-management skills, right? Of which I believe should be happening right away, right? And I want that person to be able to hold the practice accountable to answer these questions before they have to get in a car and invest their time, money, and energy. So I feel like where we're going to go here next will serve both sides of that. And what's really important is I want to look into this patient life cycle. And this is really the tipping point in my journey that really helped me to bring me to where I am today. And it was realizing again, and here's the definition I have for it. A patient journey in your practice, in your business is every single touch point. It's the telephone call, it's the paperwork, it's the parking, it's the waiting room, it's all of it. It's the greeting, it's who's going to bring them back. Are we going to greet them by name? How are we going to introduce people? How are we going to manage the first phone call? Every single step, right? This is what I call the patient life cycle. And the most successful practices, and I'd say the most successful businesses on the face of the earth, understand their client, patient, customer's journey from beginning to end. And by the way, there may not be any end. And by the way, every successful business on the face of the earth does that. And the worst at doing that is healthcare. I cuss sometimes. So if I cuss, I almost wanted to curse here. I almost wanted to curse. Of all industries on the face of the earth, shouldn't healthcare be the one that really focuses on their client, customer, patient more than anybody else? And we do it the least, right? So here's an example. This applies basically to an outpatient type physio clinic, but it can apply to a lot of different types of clinics. And I think there'd just be a couple tweaks. This is still the original graphic I created like 10 years ago for my business when I really didn't even know what I was doing. And this was a map of a client, a potential patient, because they didn't turn into a patient till that orange part down there, by the way. And this was when I really went, why are we calling people patients during this phase? And that red phase, that's someone who called the schedule, who's on the schedule, moving through all the steps. And it was really this graphic. I colored it in because when I presented it to the team, I just wanted to be able to differentiate the steps. And it really didn't occur to me that there's not a lot of orange, and that orange is the provider time with the patient. And if you think about a patient moving through a clinic, you have more contact with the non-providers than you do, right? The first phone call, maybe a billing team, you check in. And this is when it really tipped me that, man, there is a lot of time and energy spent even before they arrive that we can do positive, good things for this person we serve. And so this is the red is what I call a pre-arrival process. This is managed by your front desk team. The orange, right, is so they arrive in the clinic, they're going to have to deal with the front desk. So there's a little overlap there. When they arrive in the clinic, that's then the orange, and they see their provider. And then that course of care. The course of care could be one visit, could be 30 visits. I don't know, right? And then I have what I call that post-course of care. But right, it's this ongoing cycle and understanding these steps, because you guys can see even between these blocks, there are steps. That golden moment is when they call the schedule. Well, when you hang up the phone, all kinds of actions have to happen to keep whatever I promised to keep going so we can deliver it. So this is what I call that patient life cycle. And again, we can all sit back and think of an experience of going anywhere, a doctor, a dentist, anything recently. And it was like, how well were you managed through that life cycle? When you show up at the clinic and they don't know your name, right? We greeted everybody by name. I mean, so I'm not, there's no rocket science in this stuff, man. But we all know how impactful it is. Well, hello, Pete. Welcome. And I'm happy to see you. That's the way we greeted our new patients. Again, so all these things were happening before Pete showed up. And then when he walks in, he's greeted by his name and saying, right, I'm happy to see you. Welcome. Again, Pete's, right, his uncertainty is dropping. his doubts dropping. I think I'm in the right place. He hasn't even met his provider yet, right? So really important to understand these steps in your journey. And again, it could be from other side. And by the way, this is where I challenge the people who need the services, asking people, do you run? If they don't tell you if you run on time, ask them if they run on time. I train all my clients. If you run on time, you tell them. I train my clients who run late to frickin' share that you run late. We owe that to the people we serve. And it's not going to serve anybody good to be sitting in your waiting room for 2 hours. So again, this is from the business side, you want to be able to map all this stuff and do all this work. But from the potential patient side, you want to be able to leverage this too. The single most important thing we need to do, and you guys have already heard some examples of this throughout this life cycle. And again, the business as an ecosystem. So the early red part are the most impactful on anybody's business. And I've used some of those examples. And where I really take this training back to the teams is training everybody in the business to do this, but the front desk team has to be masters at this work. And they have to be able, and I gave multiple examples here, they have to be able to manage. So either Keith asks a question, which is an expectation, they have to manage that expectation, or if a question is not asked, we have to set it. Oh, like Keith doesn't ask if we run on time, but then the front desk says, oh, by the way, Keith, here at ABC Physiotherapy, we run on time. So this is what it means to you. We're going to send you that paperwork. If you get that paperwork filled out online, take the 15 minutes. You only have to arrive about 10 minutes early because your expert, Dr. Jane Doe, physical therapist, will be ready to see you right at 10 o'clock. So again, Pete doesn't leave his house an hour earlier. Pete knows, right? Again, all these things really start to summate, I call them. And then this whole thing, if we're managing and setting expectations, we're building trust. And all the healthcare research says the more trust, the more likely the outcome, the person on the other side will reach their desired outcome. Plain and simple. And managing and setting expectations build trust. We try way too hard on this shit. I'm like, call people by their name, right? Promise them something. Everybody always says, oh, overpromise. I'm like, no, just deliver on your promises. Healthcare has such a low bar. Why would you overpromise shit? Just make a promise. Right? We run on time, arrive 10 minutes early. And then he shows up 10 minutes early. And what happens right at 10 o'clock? His freaking provider walks out. Again, is that one thing going to make him better? No, but it's the impact of stacking that up on all these promises that were made. So we build trust by managing and then delivering on the expectations. And then this fear, doubt, and uncertainty I talk about a lot. Because if we take all these expectations out, do they run on time? What's this paperwork? Am I going to have more paperwork? Am I going to have to repeat myself? What's my doctor's name? Have they ever helped anybody like me? The clinics I work with, if Keith calls in and says, I have this diagnosis, you're going to be told whether your expert has helped someone just like you. You're not going to have to ask. But by the way, this is back to the potential patients who might be hearing this. You need to ask. Oh, you got me. By the way, I do secret callers. Pete and Keith have heard about this. I secret call clinics all the time as a potential patient. The number of times I hang up and don't know my provider's name is greater than the number of times I've given the name. And I've probably made hundreds, close to thousands of calls. I'm like, and so again, if they don't say it, who am I seeing? So they have experience helping people with ... Right. And we owe that to the person calling. So if you're not shared that, then you should be asking that. So this whole idea of this team approach, and when I first met Pete, everybody wants to go to the providers. Oh, we got to get in the medical schools. We got to get to the providers. I'm like, you know what? In my world, that's just about a quarter of it. And yes, they're the people, right? Yet, I think in this world we're in now, and Pete's heard this, and Pete's seen my conversations on this. I'm doing a lot of work with front desk teams and taking some of that clinical research and helping front desk teams learn how to triage. So does Pete need to be on the schedule? How about we don't waste Pete's time, money, and energy by telling him he has to schedule, he has to arrive. Hey, Pete, you're going to do a phone consult with your expert, Dr. Jerry Durham, tomorrow, right? So this power of going further upstream, understanding the value of all this, the listening, the managing and setting expectations, and doing what's best for that person that's calling you at that moment in time to see the right person in the right place at the right time is the responsibility before they arrive. In the current model, what do? We put everybody on the schedule so the provider can go, oh, you don't need to be here. What? Right? I waited 2 months to see you for you to tell me this, right? Stuff like that. So this is that whole idea of a team approach to patient success. And I think I'm about, I'm more than my time in. Sorry. You guys know me. I like to talk. So I'm going to stop sharing and take it away, Keith.
No, that's, we do have, I know Granny's got some questions. We don't have any in the chat, but I just want to make an observation. We got our next speaker lined up, but we got a couple of minutes. I just really appreciate your lens of looking at this, because healthcare is a business. I mean, and it is. And I worked in private industry, and profit is not a dirty word. Now in Canada, we don't have a for-profit. We call it single payer, but it's still a business. So everything you talk about is critically important. So I wanted to tell you how much I just appreciated what you brought to it, because you look at the business through the lens of the person. And you said something, and I wrote it down here. It's focusing on the person we serve.
Yeah. It's
Powerful.
that simple. And again, I go to my clients and I got a cancel problem. Oh, and we've talked about this on the calls. Oh, my damn patients are always canceling. I'm like, really? It's your damn patients?
Yeah.
You want to talk about that? Should we look at that a little bit? And then I go and look at their process upstream. I'm like, but they didn't know A, B, and C.
Yeah.
Let's see what happened. And by the way, I've done this, Keith. Let's see what happens if we change A, B, and C. And they've hired me to do this. So we change A, B, and C, 30 days, 60 days, cancels. People are arriving more. I'm like, and it is literally a matter of going upstream a couple steps and setting an expectation that they weren't doing.
Yeah. Awesome.
Again, like the paper. By the way, I had a client who went so they email everybody their paperwork. Clients are showing up with about a 20% of their clients are showing up paperwork. They're showing up early, they're showing up late. It delays care, right? Now we're running behind. We moved it upstream. I said, well, when do you guys want them to do it? Well, we'd prefer it get done before. I say, let's do this. Let's tell Keith how it benefits him to complete the paperwork beforehand. It fucking went to 80% completion rate by changing and saying, Keith, by the way, we're going to send your paperwork. And this is why I want you to get it done, because it's going to make sure we run on time. I want you to get your full hour. So if you get that done, you only need to arrive 10 minutes early. And by the way, you'll get your full hour with Dr. Jane Doe. They went from 20 to 80 in like 30 days. And I made the conversation, how does it benefit Keith? Not, you have to get your paperwork done.
Yeah. Yeah. Awesome. Granny, did you have a quick question? We got to roll on.
Always got questions for you, Jerry, and always got comments. You know that. I think what you said there, Keith, as well. I think it's really easy. I think sometimes for healthcare providers who don't necessarily work, as you say, in for-profit healthcare business. So in the UK, I think it's very easy for healthcare providers in the NHS to go, well, we're doing all this for free. It's not a business. People should be grateful that they're not having to pay for it. And actually then that can lead to this thing of, well, actually we don't have to do all this backdoor stuff because people aren't paying for it. But it's a business no matter what way you look at it. And actually we are in the business of helping and supporting people. And if we don't do that right from the start, we get out there. But my other observation just very quickly was that there's also a lot of healthcare for business who are very much in the business of not necessarily blame apportioning, but very much talking about, well, people aren't compliant with me. People aren't.
Oh, yeah.
You aren't
100%.
complying with what I want you to do. I'm trying to help here. I'm trying to give you all this information, but you're not complying with me. And when you drill down into it, as you have, a lot of that is the stress of I don't know when the appointment's going to be. You've said I'm going to, you're going to send me this. I didn't get it. If you don't get all of that backroom stuff and that admin stuff right, people aren't going to comply, but it's not because they aren't willing or wanting to engage with you. It's because the process that you're making them work with isn't working for them. So all of us as healthcare professionals, we need to remember every little bit of that. And I second what Keith said. It's a while these conferences and this stuff that we do is really important to talk about people's individual journeys as pain advocates and self-managers and the healthcare professionals, the wonderful clinical work that we can do to support them. It's really important to have this point of in with it as well, to say we can do all the wonderful clinical work we want, but if we're always late and we don't tell people what to expect, we don't help them, our clinical skill mean very little. So thank you for that. It's been brilliant. And I'll hand back to Keith and Pete for the next person. Good to see
just before I hand out to Tasha, Jerry, I also remember Dave Polt was sending me a video. It's I think it was an American medical show, not a medical show, like one of them, like a program, and the doctor. I think the doctor in it was an English doctor, but he got an American voice. But he made all the doctors be patients, and they had to be treated like patients and etc. And they had to wear the gowns and stuff like that, and it opened up their eyes. And I think sometimes there has to be that little bit of role reverse. I mean, I think we can all share sort of I call them speed bumps through healthcare, etc. But I mean, and I think I'm all the way with you. I think it's about people having that experience from the get-go.
I like to make the front desk. A lot of times with the front desk stuff, Pete, I just say, well, tell me what happened last time you called the doctor's office. What went well, what didn't? And they'll talk through it and I'll go, so how do you think we should manage it here? Right. Because all of a sudden it's weird. You get dropped. I never put the blame on the front desk people. It's always from the top. If they have no direction, they're going to take the path of least resistance. Right. So I would just say, how would you want to be managed here? Would you want to know we run on time? Everybody's like, yeah. And I said, do you know why people show up late all the time? They go, no. I go, because they never get seen on time. You got to tell them.
Yeah. Thanks, Jerry.
Thank you, guys. I really appreciate this.
Thank you, Jerry.
And I apologize. So
that's good. It means we're being successful. So it was great to have you with us. And again, just love your perspective on things. So thanks for being with us tonight.
Cheers, buddy. Cheers.
Thanks, man.
So we're going to go straight into our next presenter now. It's Tasha. I think she's going to be popping up soon, anytime now. Hello there, Tasha. How you doing? Sorry for
I'm well, Pete. You might like my t-shirt.
Oh, hey, listen. I don't know if you can.
Oh yeah, we're matching. I love it.
Yeah. Hey, Tasha, I've really groovy to have you on the out on this conference and honoured, etc. And we've not actually. This is, I think, the closest we got actually is just talking to each other on a video. I don't think we've actually met in person, have we? I don't think we haven't. Have we?
We might have at one of the pain. You came to Australian Pain Society, I think, one year, or one of the physio conferences, but it was brief. It was like 2 seconds on an escalator.
They're probably the best ones. And listen, thanks very much for coming on the presentation and giving up your time for Saturday. I was going to give the watchers and listeners a bit of an overview of who you are. So we got Dr. Tasha Stanton. Tasha is an associate professor and co-director of Impact in Health at the University of South Australia, in South Australia, and she is a clinical pain neuroscientist, which with original training as a physiotherapist, and in her research on pain, why do we have to, and why it doesn't go away. Have I read that right? In her research?
Yeah. So the focus on her research is why do we have it and why doesn't it go away?
Why do we have it? Why doesn't it go? Yeah, why doesn't it go away, Tasha?
Over to you.
$1 million question, isn't it?
We don't want it. We don't.
And you got 20 minutes.
Yeah, you've got 20 minutes. Yeah, to solve that problem.
Go for it.
Wonderful. Thank you for the introduction. Just checking. You can see my slides, right? You're seeing the right view of them?
Yeah.
Beautiful. Thank you guys so much for the invitation to speak here. I was really excited to accept and to join, I think, what's a really important conversation. Today, I want to talk about the modern story of osteoarthritis and what I see as the key role of self-management in this condition. I want to start just by announcing some of the disclosures that I bring to this. I do receive payments for lectures on pain, and I've been very fortunate to receive grant funding to support my salary as well as different projects that I've undertaken. And I also receive author royalties for a book that I was a co-author on osteoarthritis reconceptualization, and I will be talking about some of that content today. So I want to, I guess, kind of start my talk by actually talking about what self-management is, because it seems to be a concept that, we all should know, but it can be a little bit nebulous or uncertain. And so I thought what I'd share is what I have as my definition. I'm not claiming this is correct or the be all end all, but this is, I guess, in my head, how I view it and the way in which I'm probably frame my talk today. So I see self-management as or successful self-management potentially as that feeling of confidence that you know what to do. You know what works for you, not so just that you're surviving in your health condition, but you're thriving. It's also that feeling of confidence that, if things flare up, I have strategies in place. I know what to do and I know what works for me, but I also know when I might need to seek help from health professionals. But most importantly, it's being able to engage with life activities that you value, that brings that value to life. And so today I wanted to talk about self-management in the context of osteoarthritis, particularly because it's a condition for which self-management is highly recommended. And yet, if we actually look at the narrative behind osteoarthritis, it's quite at a disconnect with this narrative that self-management might be important. So, for example, if we ask people, and this holds generally, I think, for society, but if you ask people about what osteoarthritis is, this is kind of the picture that you'll get, that it's a wear and tear disease. It is the problem is it wears out the cartilage, and so that the joint itself is bone on bone, and it's very painful, and you have this vulnerable joint. And it's a degenerative condition. It just deteriorates over time. So when you pair kind of this degenerative condition that's just going to get worse, and I've already damaged my cartilage. Look, actually, I don't really think I should be doing much activity because loading this vulnerable joint is likely just going to cause more damage, more wear and tear. So I probably actually need to avoid doing activities. And for me, surgery is probably the only option because I don't have any cartilage left. And that is not an unreasonable thing to think when this is the narrative that we have of osteoarthritis. But this narrative actually goes directly against self-management principles. And because to do those valued activities, you typically have to be able to move. And all clinical guidelines support movement, exercise, physical activity. And so what I want to do today is I kind of want to challenge this narrative, and I want to explain why I think that's so important for self-management. Because if we look to the available scientific evidence, what we see is not an overwhelming amount of evidence of this is only going to get worse, but instead what we see is evidence of bioplasticity. And what this term refers to is the ability of the body tissues and the body systems to adapt or to change. And so by knowing that change is possible, and this is true of all of us, and it is true of chronic pain conditions, it's true of osteoarthritis. Change is still possible. It sometimes just can be slower. But the fact that this change is possible, it means, though, that narrative ultimately shifts from a feature of inevitability, like it's only gonna get worse, surgery is the only answer. It shifts from that to more of a message of hope that change is possible, and there are many things that we can do to further or better our condition. And so, what I want to do today is actually want to talk through some of the assumptions that we hold that really are the pillars of that narrative of osteoarthritis, but that are pillars in which I actually think are quite unhelpful. And the first relates to cartilage. And all these assumptions I've decided to pair with a judgmental cat so that you can remember that they're assumptions and these are not facts. But in this case, the judgmental cat is talking about our assumption that actually cartilage is a static inert tissue, and once you have any damage to it, it actually can only get worse with more loading. And this is a really widespread thought or narrative. And it's quite confusing because then when we actually look to the literature, we don't necessarily see evidence of this. So we see that actually cartilage seems to love loading and it can adapt. So if you look at an astronaut that goes to space, so it's microgravity, it's your ultimate anti-loading environment for cartilage. When they come back to their Earth, actually their cartilage is less healthy. And if we look to the opposite ends of the spectrum, where we have a marathon runner, where they're obviously loading their cartilage a lot, their cartilage is healthier than people who are sedentary and not active. And that kind of weird disconnect, it actually makes a bit more sense if we think about the physiology of cartilage. So it is a vascular, a neural, a lymphatic. It does not have blood, nerve, or lymphatic supply. So the only way that it gets its nutrients is actually through literal compression and load. And we know that actually the specialized cells in cartilage that are called chondrocytes, it's load that ultimately, propels them out so that they actually can go to different areas and make features of the cartilage, such as collagen and aggrecan, tough stuff and sticky stuff that helps build the strength of the cartilage. So instead of saying, wear and tear and things like bone on bone, actually what we should be saying is move to improve. Because we see actually that this positive benefit of load on cartilage extends to people that are either prone to or have osteoarthritis. So this was a pretty cool study quite a few years ago, but it was looking at middle-aged patients who had what was called a degenerative meniscal tear. So a tear that sort of just happened with, a quick movement potentially of their big, thick cartilage in their knee, the meniscus. And they ultimately went and had a surgery to remove that, a meniscectomy. Now, people that get this surgery, they're at higher risk of developing what's called radiographic OA, so osteoarthritis that you see on an X-ray. And in this study, they took this cohort of people and they randomized them to either get 4 months of exercise or 4 months of no intervention. So they just do what they normally do. And what they found is that actually, or they looked at the health of their cartilage using MRI. And this is their cool findings. I'm just going to draw your attention to this part of the graph, all those dark fill-in dots. Those are the people that were in the exercise group. Only people in the exercise group had increases or improvements in their cartilage health. Everyone else either was unchanged or reduced. And that's really interesting because when they looked at the data a little bit more closely, they found that the more physical activity people did, the greater the improvement in cartilage health. So first of all, this is just showing this is bioplasticity at work. And we see this in, knee osteoarthritis. There's a lovely study that's looking at self-paced running in people who have knee osteoarthritis. And it shows that starting to run doesn't damage their joints. And in fact, many features actually improve. And so it's all about getting the load or the activity right for that person. And I'm going to come back to that a little bit later in my talk. But this is a lovely example of bioplasticity. The other assumption brought to you by this judgmental cat is that, okay, if I have osteoarthritis and it hurts when I move, then it means that I'm further damaging the joint. So that's my sign that I shouldn't be moving. But again, when we look into the scientific literature, we actually have evidence to suggest that there are changes in people with osteoarthritis in the way that their pain system is working, such that the ability to dampen down or decrease sensitivity isn't working very well, and the ability to ramp up sensitivity is working very well. So we have this system this circumstance where it's like the system is overprotective. Another way we call this is hypersensitivity. So in addition to the changes in the way the pain system's working, we also see evidence that actually osteoarthritis involves what's called systemic or increased systemic or body-wide inflammation. And this inflammation can occur just as we get older, it can we have higher levels of inflammation if we have higher levels of body fat, but it also can happen even as a function of gut problems. So our microbiome, our gut bacteria, they talk to different areas of our body and our circulation. So if we're not doing well in our gut, actually we tend to have higher levels of inflammation. And this higher level of inflammation helps make the pain system very sensitive. So it means that when we think about what's happening in terms of pain experience during movement, there's actually a lot going on. Because if we think of a healthy individual, and this mountain is how much they can move, if they do a crazy amount of activity, they'll breach tissue capacity. We can injure ourselves. But pain is lovely because it actually typically, as long as we don't do things too fast, it typically comes on before we injure ourselves. We all have that safety buffer in place. Now, for a person with osteoarthritis, actually, there are changes in the tissue, so it's likely that their tissue capacity is reduced a little bit relative to someone who's without osteoarthritis. But in the presence of that systemic inflammation of all these changes to the pain system, it actually means that that safety buffer is much bigger. So that when we're doing activity and we feel pain, actually we're just pushing into that safety buffer. We're nowhere near that tissue capacity. That system itself is somewhat overprotective. But knowing that actually we're just pushing into the safety buffer when we start to feel some pain with activity can be very freeing, because it can also mean it's actually okay to feel a bit sore because I'm actually still safe. I've worked with my health practitioner and I'm nowhere near damaging tissue capacity. We also know that safety buffer or overprotection can also be maintained by lots of other different things that I'm going to come back to in a couple minutes. But the good news of all of this stuff is that big enhanced safety buffer. We've done some work to show that when we increase people's knowledge and understanding of their condition, in this case osteoarthritis, and the importance of activity and how to start to improve and increase activity, what we start to see is that safety buffer starts to reduce. So people can do more activity with less pain. And again, I would argue that this is evidence of bioplasticity at work. So instead of this idea of like, oh yeah, I'm going to do a little bit of exercise so that I can stave off the decline of osteoarthritis, I think we reframe the narrative and we start to talk about steps to osteoarthritis improvement or even recovery. And the evidence suggests that there are 3 key ingredients to this. A little bit like baking bread, best if they're all there. But in this case, this is increasing people's knowledge, increasing or optimizing activity, and decreasing inflammation. And all of these things are parts of self-management, things that we can do and take on ourselves to manage this condition. I'm going to start and talk through a couple of these things. I've already introduced you to some of this idea of increasing knowledge and of shifting the narrative of osteoarthritis. And ultimately moving from this old view where we sort of think it's only the knee joint that's a problem. It's mechanical wear and tear. It's only going to get worse. And really shifting it to this idea that actually osteoarthritis is a whole body, mild, low-level inflammatory process that can manifest in any joint, including the knee. But importantly, that many factors contribute to osteoarthritis itself, but also to the pain you feel with it. And because there are all these different factors that can contribute, it also means the future can be constructed. It can be changed. There are things that you can do that mean it can improve. So that's a very different mindset to go into osteoarthritis, isn't it? I think it's also relevant to kind of come back to this idea that there are many contributors to a pain experience, because in the past, we had this idea that how much pain we feel is just a readout of, how much damage or tissue injury there is. And one of the theories, and it's certainly one that we've worked with within our groups, suggests that it's a bit more complex than that. Because in fact, we have this dynamic system that is always adapting and updating based on the available information for us, in the environment that we're in, and also in the society that we're part of. And the system is about protection. It's determining whether or not we need to be protected. And so it's balancing up the available information of danger and the available information of safety. And if danger wins out, it helps determine or influence how much we hurt. Because actually, pain is a great way to protect us. It catches attention, it makes us change what we're doing. But the important part of that then is that anything then that suggests that you need protecting or that you're in danger has the potential that it may be able to increase pain. And the alternate is true. Anything that suggests you don't need protecting can potentially reduce pain. And so, as part of a self-management strategy, actually determining and understanding your own unique balance of danger in me's and safety in me's, or Noy Group calls this dim sims, but can potentially be really powerful to understanding the symptoms that you're experiencing and the pain that you're feeling, but also give that level of control of things that I can do about this potentially. So, for example, dangers can be things that you see, things like looking at your x-ray. That can be terrifying, seeing that. Whereas a safety might be actually taking a moment to think about and reflect upon the strength that you feel in your thigh muscles. Knee exercises, depending on your narrative of osteoarthritis and your understanding, that might be a danger, feeling pain with those. Whereas if we understand that actually exercise can be really beneficial, maybe that same thing can be a safety. Words like wear and tear, throw that out, maybe positive ones like move to improve. Different things like thinking that surgery is inevitable versus there are actually many ways to improve my OA. Places you might be, a doctor's office, the smells that you have in there versus choosing to be at a dance class with your best friend, people around you that, might be an out-of-date health professional, a nosy neighbor, up-to-date health professional, supportive family, as well as just how we feel, whether we're depressed, anxious, or actually we're feeling optimistic about the potential of a different future. And all of these things matter. The second of these self-management strategies that are on the steps to recovery is this idea of increasing and optimizing our activity. And the key in this, I mentioned before, it's about getting that activity right. And it's finding for each individual the activity or amount of physical activity or exercise that's right for you. What is your sweet zone? The not too much, not too little, but just right. Sometimes also called the Goldilocks or Cinderella zone. And we often know we're in the too much zone is if we do something and we get increases in knee pain or swelling that don't settle quite quickly, or a lot of fatigue or feeling of muscle weakness that extends past that activity. But the too little zone might be you don't actually feel anything at all, like you didn't really feel like you did anything new. Or when you were doing the activity, you didn't actually feel like your effort or breathing rate even increased much more than when you were sitting resting. But ultimately, it's trying to find that sweet zone for you. And so I want to give an example of how we might do this using, this is just an example case study called Todd. And his valued life activity or his goal was really to be able to walk to the playground with his grandkids and be able to play with them while there. And that walk was about 30 minutes. So his goal was ultimately to get to the walk to that distance. So what do? We find the start point. We have Todd discover. He's on a mission of discovery to take 2 or 3 walks over the next week. Try to choose relatively flat if he can. And just thinking generally about how long you typically walk for, and you can start about there. And we want, in this case, to walk until you either experience symptoms that might actually not settle down super quickly after you stop, or you experience a bigger than normal increase in symptoms while you're walking. Or you feel tired and notice you're less able to control the movement of your legs. This sounds counterintuitive, doesn't it? But what we want to do is when this is occurring, we want to record how far or long you were able to walk, writing down distance or time. Because what this is allowing us to do is to discover your sweet zone. So in this case, we're trying to find that upper edge of the sweet zone where you tip into the amount that's just right for you to the little bit too much. And then once we know that, perfect, we can change and determine how much activity you might want to do. So for Todd, week 1, it was figuring out where to start. He decided to walk with his partner. And first walk he went for 15 minutes, second walk, 22, third walk, about 17. And in each case, it tended to be either an increase in pain or increased fatigue that stopped that walk. So where do we start then? Go with the middle. Not too little, not too much. Go with right in the middle. So Todd then started in the next week again to go for 3 walks, but aiming this time for that middle time, about 17 minutes for each walk. So we're ensuring that he's right in his sweet zone. Hot tips we give him: make sure to spread the walks throughout the week. But also, when you're thinking about when you want to put them, think about the other tasks that are going on, because it's quite easy actually when you're adding a new activity, to forget that you're actually doing a lot, like a big grocery shopping trip or something like that. And to put it in your calendar, plan it out, because otherwise it can be easily missed. And then what do we do the next week? We just do a little bit more. Again, 3 walks. In this case, because Todd's trying to get up to 30 minutes, hot tips: stick to the plan. And this is important because even if you feel really good, it's quite important not to just go way further, because this is about giving your tissues and your systems time to adapt to that increasing load. Cartilage takes time, muscles take time. And also, if you feel a bit more sore, doing your best to stick to the plan time. But if you do feel those, increases in pain or swelling, absolutely okay to do less. We don't want to beat ourselves up. So Todd, week 4, 3 walks, but again, just going a little bit further. But what if he had a big increase in pain when he did this for the first time? Well, actually, he knows what to do. He can just pop down to walks of a little bit less duration, because perhaps we pushed into the too much zone. And it's that bit of like, all right, don't panic. Let's have a check-in and think what things might have been different this week that might have contributed a little bit more to pain. So Todd thinks and says, well, I did walk up a hill that was a bit bigger than normal when I added that extra time. My car broke down, and actually that was really stressed, and I was worried about getting it fixed. I didn't sleep well the night before, but also when that pain increased, it made me think, actually, is this really safe for my knee? So what's happened? These are danger in me's, aren't they? What do DIMS do? They make the sweet zone smaller. So Todd is able to do less activity before he experiences pain. But it also means then that we can maximize Todd's sweet zone by reducing DIMS and adding or enhancing SIMs. So if one of his DIMS was worry or fear if this is right for him, all right, had a chat with his physio about his increase in knee pain. He also then explained to his partner some of the ways that he knows that exercise helps his joint. His car's still not fixed, so maybe we can't shift that right away. So instead, maybe what we'll do is add a new safety in me. And instead of walking near his house in the city, he's chose to have a walk in nature. So there's lots of things that we can do to start to optimize and increase activity. The third is decreasing inflammation. I'm not going to spend much time on it, because actually increasing knowledge to reduce fear and worry, increasing activity and making it a habitual daily thing are beautiful ways to decrease inflammation. And the third way to kind of do it is to talk to a nutritionist or dietitian about trying to use kind of a more anti-inflammatory diet. I know I'm a little bit over time. I just want to quickly chat about some of the new resources and programs, and just let you know of some of the work that's upcoming. One is a self-management book that we created that I referred to before, that this is for people with knee osteoarthritis as well as their clinicians. So it can be used for self-management or for supported self-management. And we're just at the process of analyzing the data from a big trial to see if this was efficacious over the long term for people with knee osteoarthritis. But this is freely available if people find it helpful, and it goes through some of the knowledge changes as well as activity increases in a little bit more detail. The second is some really cool stuff that's being led by my PhD student, Monique Wilson. And the first one is called the Pain Plan. It's a personalized learning and navigation plan for pain science resources. And the idea is you can personalize every of this. It's linked to a pain education hub, and as well as these kind of infographic cards, but it's initially for a physiotherapist or an exercise physiologist to use to create a personalized plan for people who are seeing them to do in between appointments. So we're trying to really kind of keep the momentum going and help people feel supported, but it also could be a lovely resource to use for a supported self-management plan where you're actually not seeing your clinician very often. We're testing this resource, so if you're a physio or anyone like that interested in being involved, contact Monique. And then the second one that Monique is working on is an OA Champions program, which is really a community-based peer mentorship program for people with knee osteoarthritis, with the idea being that if we pair people who are, throughout their osteoarthritis journey, but we pair them with people who are successfully self-managing the condition, that can be a really powerful resource for those people on their own journey. So to summarize today, I hope what you came away with that the modern story of osteoarthritis is bright, I would argue, because we are bioplastic, we are changeable, and this doesn't stop just because we have osteoarthritis. I'm going to say no more talk about inevitable decline. We throw that from our vernacular. Instead, let's focus on the key ingredients to improvement and recovery, which are increasing knowledge, increasing activity, and decreasing inflammation. And these key ingredients are self-management. They're the best ways that we are aware of. All guidelines suggest them to retrain this overprotective pain system and also encourage cartilage health. So on that note, I want to thank you for your time and your attention and just say a big thank you to my team and some of the funding resources that we've had. Thank you.
Wow, that was amazing. That was awesome. What'd you think, Pete?
Wow,
Yeah.
Oh, thanks, friends.
it was lovely.
Um,
I'll tell you what I got from it, the passion, you know,
Thanks,
you're,
Pete.
you got the energy, baby, you know, and that's what,
I,
relaxing a lot of people, but fantastic messages and stuff, you know.
I really
How can we,
wanted to say,
how can we put you in a jelly mold, Tasha, and
yeah,
well, all the speakers tonight, you know,
yeah.
we need to put well, I feel when I win the lottery, I'm going to make a jelly mold of all you great speakers. So well done, thanks, Tasha.
That's so kind. Cheers.
I don't know if we have any questions online, but I have a comment because I always do. That was awesome. There's a couple of things that really resonated with me. And one of it was the words that are used, especially in the clinical setting, right? That sort of degenerative and surgery is the only option. And I love how you talked about the importance of changing that narrative, but also like educating people. I loved the the move to improve and that whole graphic he had with the astronaut in space and how the cartilage actually lessened versus I'm no marathon runner and I never will be. But that kind of movement and loading, because we hear a lot about that loading and how it actually improves it. And I think that really, really challenges a lot of people's perceptions and beliefs. So this is the kind of research that is really important to get it sort of out of the labs and into the clinical settings and into society. So my God, everybody who's talked so far, just like you just ring my bias bell. It's just been wonderful. I mean, it's the biggest echo chamber I've ever been in. I love it all. So Tash, that was amazing. And I'm just so appreciative that you joined us today.
Oh, thank
Uh,
you.
Can I just add, I live with osteoarthritis in my knees, and I don't know, it's back in towards the back end of last year. I was struggling to, it was a struggle getting out of seats. So I thought to myself, I know what to do. I need to do some other exercises. Happy days.
Yeah.
Yeah.
For me, I don't know what it is. It's just for me anyway, personally,
Yeah.
exercise seems to be in my body like, you know.
Yeah.
So,
And I think that that's actually such an important point, Pete, because we've had a couple of studies that are running where we're using like virtual reality or mediated reality to help improve exercise experiences for people. And one of the things that's really resonated with me and I was really like it's quite powerful is that many people when they come into our studies, they don't think that they're capable of doing that. And the
Mm.
amount that they come out with at the end, it's such an empowering journey because they've gone from something they're like, oh no, I don't think that's for me. But you've got someone there that's sort of helping them through the process. And they come out and so we had a cycling study and there were probably about half of our people like bought a bike and they're regularly doing this. And we had another person in one of our studies who it was so interesting. She went through this our whole like quite a long walking program and education program and did very, very well. And she then volunteered for one of our other studies, but as a one of the healthy control groups. And we had to say, oh, I'm sorry, like we know that you have osteoarthritis from this past trial. You can't be in our control group because you have arthritis. But for her, there was sufficient change that she didn't identify as having that condition. And
Mm.
that was that was such a powerful realization. And I think there's like that aspect of when we move and do things that we also feel more confident in ourselves and our own capacity. And I think that's a really in addition to all the positive things it's doing to the way our pain system regulates, our ability to inhibit, all of those things are really
Yeah.
positive. But I think that locus of control that I can do this and I've got this is just such an important part of
Yeah.
it.
Yeah, I love that it changes the focus away from what I can't do to what I can do. And
Yes,
that's so
Yeah.
important. So yeah.
100%.
And as as I've sort of become an older person, funny, I've just last the other week I've adapted one of the booklets that myself and Keith wrote, 2023, about prehab. That for uh, prehab, in other words, for getting older. So don't wait until you've got these problems, but why don't
Yeah.
we start, getting ready for being an older person? And
Yeah.
I mean, I've never been 71 before. Is it am I 71? Yeah, I'm 71, and I've never been. So, but I'm thinking, well, okay, this is where I am now, but I need to prepare for when I'm 72, 73. So to me, it's how do I do that? It's like stepping it up things and through, all what you've been mentioning tonight, really, So.
Yeah.
But I think we seem to carry on until, I don't know, I feel, what's going on, and then, just it's you got to do more. I think more thinking forward, not projecting, but start preparing for being an older person, or prepare. We do when we prepare for a journey, don't we? We make sure we got a ticket, or we got the tanks filled up in the car or a van. So but we seem to wait until we're in a problem, and then, what do we do now?
Yeah.
So
It's so true, isn't it? We're very often a reactive mindset rather than
yeah,
proactive. Yeah,
yeah.
100%.
Our NHS is like that. It's a firefighting service, really. It's like
Yeah.
they can see people in trouble, yeah, but
Yeah.
they're not quite on fire yet. They see the smoke. Oh, yeah, they're
Good
all right.
water for you.
Yeah, well, wait until they burst into flames, or they end up in A&E, and then we'll put them in deal with them, Hey,
Yeah.
listen, I'm gonna let you go.
Hey,
Uh,
hey guys, it's Margaret here. Can I just tell Tash something, please, quickly?
Yes, please. Mhm.
Hi Tash, Margaret Knight. How you going? Um,
Hi.
I've got my handbook for my knee, but I just wanted to tell you that I recorded the automatic window up and down in my car, and it's helping with my knee stiffness. So I listen to it when I move my knee, and it's moving better.
Amazing. Oh, I love that. Yeah, we're always trying to find different sounds. So like
Well,
of nice movement. So that's brilliant. Oh my
yeah,
gosh, amazing, Margaret.
it's fantastic. Yep, great.
Awesome. Oh, thank you for sharing that, Margaret. It sounds like it was a real
nice to
home
meet
run.
you, Margaret.
Yeah. I think we got to move on. We got
Yeah,
Dr. Hayes who's up next, and Pete, should we just keep on rolling along here, or what do you think?
yeah. I think we just keep on
Okay.
keep doing it. Yeah, I think
All right. Again, Tash, thanks so much for joining us. It's great to have another Canadian who isn't in Canada anymore join us, but it's always nice to have you join us. So lovely to
Absolute pleasure. Thank you so much, you guys. Really great
great.
job organizing this.
take care.
Great. Thanks,
Stay
Tash.
safe. Be cool.
All right. Take care. All right, with that, we're going to jump right into our next presenter, and I haven't had the privilege of meeting you yet, Dr. Hayes. But there's been a bunch of presenters so far, so the bar's been set pretty high. But I hear you could have no problem knocking this out of the park. So
It's up there, baby.
I've got a little bit of an intro for you that I've stolen off the internet. So if I get it wrong, I apologize, because everything on the internet is correct, right? There's no such thing as false information on the internet. So thank you so much for joining us today. That's tonight for me. Next presenter is Dr. Chris Hayes. Dr. Hayes is a pain medicine physician at the John Hunter Hospital Integrated Pain Service. in Newcastle in Australia, and he's a co-joint senior lecturer in the School of Medicine and Public Health at the University of Newcastle. I hope all of that was correct.
It is indeed.
All right, excellent. Over to you, sir.
It is great, thank you. As I'm just checking slides, can you all see my slides?
Yes.
We sure can.
Great to be able to follow in Tasha's footsteps. She's one of our key trailblazers in Australia, although I would say that she, like you, Pete, is making me feel a little underdressed. I've got a boring conservative collar and conventional shirt rather than the pain toolkit emblazoned upon me.
Oh dear.
Oh dear. I am, disclosures, I'm a doctor, a pain medicine physician, which could potentially draw me into dark places away from self-management, but hopefully not too much. I'm talking about the perspective developed within our multidisciplinary team under Integrated Pain Service. So very much our team's wisdom on how we support people to self-manage. So we talk about supported self-assessment, and we talk about how to support people as they self-manage. So acknowledging the team pictured in the centre there. On the left of the screen, my work home. This is at John Hunter Hospital, Newcastle, New South Wales, Australia, just up north of Sydney. On the right of the screen, this is where I live with the eldest of my 5 grandchildren now sitting beside me, looking from the hills across the coastal strip to Newcastle and the ocean beyond. I would like to acknowledge our First Nations people, Wabakal country where I'm from. This illustration is beautiful, I think, in terms of the multiple layers involved in self-management. And I know Tasha's been tapping into this. It's not a simple linear thing. And in this, the multiple layers represent the country, the physical landscape, the people, the pain, the mind, and at the centre, some bush tucker, as it might be called in Australia. All these multiple components contribute to the picture, contribute to, as Tash was talking, the pain system and how sensitised it might not or might be. From our team's perspective, somewhat parallel, I think, to Stanton, Butler, Mosley. We've spent much time thinking about language, what is person-centred, patient-centred language in this holistic game. So we have found these words good. Language clearly is fluid, so that can change over time. So this is today's language, could be different in 5 or 10 years' time. But this, we find this works pretty well in the group of people coming in to see us in a hospital multidisciplinary pain clinic. We use this as a framework to help people self-assess the different components of their life and then follow on to the self-management treatment phase as well. So you can see the 5-finger approach, which we've thought about a lot. That's, I think finding that sweet spot. Tash was talking about that in terms of finding the sweet spot in terms of physical loading. Let me just apply that a little bit more broadly, finding the sweet spot in terms of how much biomedical intervention, if we're thinking about knee osteoarthritis, still, there probably is, I think, a place for knee replacement surgery, but that's not the dominant place. So in our way of apportioning this, the biomedical, be it drugs, surgery, whatever, that's about 1/5 of the overall picture. I think hands and fingers are convenient. And the other 4 fingers there are what we would call active self-management approaches. One is not just passively receiving those things, the mind-body connection, activity and nutrition. We do, as I mentioned before, encourage this idea, which I think is quite neat, self-assessment as a prelude to self-management. So good to be stepped back a little bit from rushing into self-management. Self-assessment is a good starting point to figure out various things, including which finger you might be wanting to focus on at the moment. In knee osteoarthritis, I think clearly that ring finger, the activity domain, is a very important part. However, that is individually variable. Tasha again mentioned the nutrition, anti-inflammatory eating is a key part of it as well. So once I've done a bit of a broader intro, I thought I would just, because they're a little bit less publicized, I think, talk about in particular the mind, body and the nutrition fingers, both of which I have an interest in. But first, just thinking a little bit about the biomedical interventions, and I thought I would just take opioid medications as a symbolic part of that, which is to acknowledge, I am a doctor, I did disclaim that earlier, there is a place for these things. There is a place for opioids. I think there is a place for knee replacement, I think, as well. But we need to nuance those things a lot. And there is clearly a potential for people to be drawn too much to the dark side of over focusing on biomedical interventions and losing the opportunity of the other four fingers, so to speak. In my interpretation of the evidence base, I would say that opioids are pretty good for acute pain. If you've broken your leg, just had an operation, they're moderately good for cancer pain, palliative care at the end of life. And if you have opioid use disorder, the evidence doesn't say that you should use opioids all the time there, but selective use of opioids is good. On the other hand, standard approaches, I would argue, in chronic non-cancer pain, the evidence generally would say that harm outweighs benefit, which does leave some grey zones to think about. What about recurrent pains like renal colic? When does someone transition into that palliative care phase? So there's the pre-palliative thing, the frail elderly phase. They're kind of grey zones where opioids might or might not have a role. So I think in focusing on self-management, we just need to be a bit careful not to totally discount biomedical interventions, but just recognise the selected, somewhat limited place that they have. This guy's quite a cool character. I don't know if you know him, Pete. Adam Meekins is a physio from the UK, and he's spent quite a lot of time putting this question: is there a window of opportunity? So does the biomedical intervention create a window of opportunity to do the other things? It's a good question. It's one for people to ask themselves. In the group of people that I see, as a team, we largely think no in chronic non-cancer pain. Biomedical intervention very rarely, if at all, causes a window of opportunity. Mostly it distracts people from the main game. And you can think about this in terms of that behaviour change wheel. We've liked over the years Susan Michie, a behaviour change person, again, done a bit of work in the NHS, thinking about the green in the centre, that's the person with the pain, what's their capability, opportunity and motivation. And then from the medical perspective, that's the red in the outside circle. So I guess you can think through there, does an excessive focus on biomedical intervention impede behaviour change? And just in passing, the grey outer circle, guidelines and regulations, legislation and so forth. So this is our one-page summary of our team's approach, a lot in common with what Tasha was talking about, I think. The hope messages there: be curious, recovery is possible, keeping in mind the fluid definitions of recovery. So you can see some of our language. These are key messages that we've spent quite a bit of time pondering as a team. Not to go through all of this, but biomedical, you can see your pain system can be overactive or overprotective or oversensitized. Your scan does not explain your pain. Long-term medications can be slowly reduced. The activity moving is safe. Strength training boosts recovery. And I'll focus a little bit more after I mentioned connection to people and place is valuable, kind of a nice First Nations Aboriginal reflection from Australia. Building a support team is good. I'll focus a bit more on the mind, body, and the nutrition now. This is a template of a document that we use to help people just think through the balance of that self-management approach and what they would like to work on. I won't spend too much time on that now, but by all means, if you wish, take a photo of that and you can use that as a template to review life. I very much like, and our team like, the broad approach or the broad view. So medically, what I'm usually doing if someone's coming in with their chronic non-cancer pain for a discussion is to say, let's broaden the approach. Most people we see are more narrowly biomedical, so this is a tool to broaden it out. Self-assessment ahead of self-management. Okay, remaining time, just want to talk a bit about nutrition for one and the mind-body aspect for two. So we have two key nutrition messages which are angled into that anti-inflammatory eating frame. And message number one is positively framed: eat more of the good stuff. So eat a variety of real whole foods. So what we're meaning by there is foods that is not in a packet, foods that your grandmother would recognize or have on her pantry shelves. So be that meat, fish, eggs, dairy, fruit, veggies, nuts, and so forth. And our second key message is limit the not so good stuff, limit highly processed foods. So this tends to be the modern industrial processed food that has potential to inflame our bodies. Just a call out there to what I think is a very fascinating trial done by Rowena Field. She's a physio based in Sydney during her PhD. She did this study looking at lower carbohydrate eating in a cohort of people with chronic pain and found interesting reduction in pain levels and inflammatory biomarkers as well. I'm currently in the midst of a PhD looking at teasing out this fascinating triangulation between nutrition, inflammation, and chronic pain for my sins. This is something we've been working on as a team. This is completely non-validated, but if you are interested, again, I won't go through it in detail with the constraints of time now, but if you wanted to take a photo of that and score yourself afterwards, this is designed to be a much shorter form of something that could be used as opposed to many of the long form nutritional assessments. So the idea is that this looks, or there are 2 questions on one of our key messages and 3 questions on the other. You score a maximum of 5 on each of those 5 questions, and a higher score suggests a more healthy eating pattern. So the closer you get to 25, the better. The closer you are to 0, the worser. So we've been finding that quite good to push beyond that initial conversation of people saying, I eat really well, thank you. This digs into the detail in quite a helpful way. Recognizing what we eat is quite a personal thing. It's also quite an emotional and political thing as well. I do like hands. I've liked that 5-finger thing. This is a hand model from the States, Dr. John Berardi, but I kind of like this model of using the hand, and the measures in the hand change with the size of the person and the size of their hand. Bigger people have bigger hands and need to eat more. But the idea with each of these 4 measures is that for a person, depending on their activity levels, might eat one of these portions, one of each of the 4 portions with each meal. If they're more active, they might balance it out to 2. And there are ways to tweak this according to whether you want to lose weight, gain weight, etc. But the palm is the portion that guides how much steak we eat. For me at the moment, I'm pretty active and I like 2 portions of each of these. This is an approach to a balanced diet. So 2 palms of steak equivalent with each meal. The fist is the non-starchy veggies, so the green, predominantly veggies, but multicolored. 2 of those I'm aiming for. The cupped hand, try and get this right on the on the angle of the video, that's for the carbohydrate rich foods, but not the super refined carbohydrate things. So that could be some rice, it could be some sweet potato. And the smaller portion of fats is the thumb, so that could be some nuts. So this is a way of achieving that balanced diet. It is a bit different and it nudges into lower carbohydrate eating than traditional dietary guidelines, I think, in Australia or the US or the UK. I don't mind a little bit less carb for most people, unless you are that marathon runner. It's a different thing. Okay, moving along, mind, body. Exploring beliefs and emotions can lead to less pain. And a key question that we asked, what else was happening when the pain began? Again, this is something that we would encourage people to be curious about. And I think in our team's experience where people do, which clearly not everyone does, but some people can move through to abolition of chronic pain, even if they've had it for 5 or 10 or 20 years. If they're in that cohort where that's possible, in my experiences, usually because they've made a mind-body link. You know, the pain came on or the pain was exacerbated at a time of significant life trauma. This is Brain Man, our team's little cartoon character. You can see he's injured his leg, but not in isolation. Life happens. It's in the context of those things illustrated behind there. This is a nice exercise that we get people to consider the life timeline from birth through to now. On one side of the line, you can plot life events, particularly with a focus on the more traumatic ones, and on the underside of the line, the health problems, and one is looking for correlation. Did my onset of pain or my heart attack or my onset of type 2 diabetes follow a significant life trauma event, which isn't to say that unpacking that leads to resolution necessarily, but it can be strongly therapeutic. I've put just a reference down there on what I still think is a bit of a newer zone in pain management, which is an emotional focus as opposed to more cognitive focused psychological therapy. So this is something called emotional awareness and expression therapy. There are lots of forms of psychological therapy that are more emotionally focused. The old school CBT can come across, I think, as a bit judgy. You're a naughty catastrophizer, etc. I find the emotions-focused therapy go a bit deeper, essentially, and not to bully people into doing that. It's good to have 5 fingers so they've got options. But for someone who's curious and would like to go there, it's often good. Another hand, this is Dan Siegel, American developmental psychiatrist. You can see in the picture there that the wrist is the spinal cord coming up onto the hand or the brain stem, and the thumb folding across is the limbic system, or the physical seat of the emotions, if you can call it that, which are then covered by the cortex of the brain that comes over there, which is to say that the emotions can often be hidden by a mess of busy cognitions. So the idea is that becoming aware of what's happening in that limbic system, as one might do with some emotions-focused therapy, can be a good way to wind down a wound-up pain system. Last slide, back to Indigenous art. This is hope. This is new growth. These are some beautiful plants growing out of some fertile Australian soils. And that's the message we're wanting to convey. I think Tasha ended on that point as well. It's a message of hope. We are bioplastic and beyond bioplastic. We're psychoplastic and connection plastic, spiritual plastic, if you want to go there. All these things are layers of plasticity which bring hope. That's the end of mine. Thank you. Happy to take any questions.
Great. Thanks, Chris. That was, again, it just, every talk just builds off the next one and it's better and better. I love all the hand analogies. I did take some photos and I'm sitting there following along with you. So, I don't don't know if we have any. I don't think we have any questions in the chat, but I think Grania, do you have some
Always,
thoughts?
always
Yes.
questions and comments and observations. Yes, another amazing talk. I do think what I'm loving particularly about this year's conference is the fact that although this is all about supported self-management, we are having lots of speakers acknowledging all of the other aspects of managing with and living with pain. And I do think it is important that we do remember that there is still, for some people at some times, a place for more interventional or biomedical or medical sort of help and support. But as spoken by previous people, that often has to come in alongside other things and not at the expense of, and that all aspects have to be dealt with. So I think that's really brilliant. I was interested in what you said there about the emotional therapy. So the particular one you talked about, I'm not familiar with, but there's quite a lot of debate amongst colleagues that I've worked with over here around the role of what's called compassion focused therapy here, which is about more about emotions. And I've certainly seen that, and I would agree that, you know, the older fashioned sort of more of that CBT model, there was often a lot of issues with that, but looking at people being able to be compassionate themselves and becoming more emotionally aware of things can often feel like a kinder approach, and they can be kinder to themselves. So I think it's really interesting and just really encouraging to see how we're all just keeping learning, and we're all just willing to embrace new things and try new things and not be stuck in our ways. So that's amazing.
Yeah, thanks. It is.
Sorry, go ahead.
It is good, and the breadth is good. And yeah, we've really liked the fact that we have 5 fingers on our hands, because it gives people choices, and you can weave around. You know, as you say, hip. Well, you know, we use that example often, that knee replacement or hip replacement can be the exception that proves the rule of biomedical intervention not working very well for chronic pain, because for the right person, right time, right place and all that, it can be a beautiful thing. Noting Pete's comments earlier about the prehab thing and the post-hab thing can be part of it as well.
I just wanted to mention, I you know, all the speakers and then Chris, your talk, you know, I love the focus on the body-mind connection, right? I think we can agree, or hopefully we can all agree, that with all due respect to Descartes, it was wrong. They are not separate. There is no dualism. And I like how, you know, there's been the focus, and you talk about, you know, the environment in which people live in or a part of, you know, affects them. You had the little graphic, you know, the stress of loss of job and finances and all that. And that really speaks to me about that concept of what I'm really getting into is sort of the synactivism, which takes the biopsychosocial framework and then kind of goes bigger to the synactive view of the environment in which we exist enacts upon us and all those stressors. So yeah, I loved all that and the images. And again, my echo chamber just continues to grow all night long here. So I'm just super excited about all of this. So thank you.
It is interesting. I wasn't particularly calling out the middle finger of that today, but we would say that as a fairly standard thing to people coming in to us, that the connection finger is the middle finger, and for most of us the longest finger, which is to highlight that importance, I think, of connection to each other and connection to the natural world, the environment as well. And it is very hard, I think, to wind down a pain system, probably impossible if one's in an unsafe place in terms of, you know, whatever it is, domestic violence or unsafe housing, you know, these kind of things. Not that we obviously have simple solutions to that, but it is something to be aware of, I think, in planning a self-management strategy. You know, can I move towards safety, I suppose, if I'm not feeling safe at the moment?
Again, and I know we gotta move on here, but I'm just so excited about all of this. But to me, a lot of that speaks to, we hear a lot of this, and I am an absolute non-advocate of the dreaded pain scale, because it has barely any use, maybe a measure of a change, but you know, that worst pain ever. But we hear all too often healthcare providers say, oh, somebody said they had a 10 out of a 10 or 12 out of 10. You know, they're lying, they're drug seeking. I think often what they're doing is they're presenting with, my pain is bad, but then so is all of this environmental impact on me. And it is wound up And when I say it's 12 out of 10, it's because I can't see straight because of everything going on in my life. And with a bit more compassion and humanity, I think healthcare has an ability to wind that down. But we haven't taught a lot of healthcare providers to just be compassionate instead of trying to fix it right away. So that's my soapbox. Sorry.
Yeah, looking at that comment about the compassion focused therapy, picking up a lot on that safety danger thing. And as we know, the NOI group in Australia, the DIMS and SIMS have been down that line for a while. So yes, that deeper emotion is pretty important, I think, in terms of how we sit in day-to-day life. You know, as I'm sitting here, do I feel safe or do I feel stressed or in danger? These are important things to ask ourselves and to be aware of.
Chris, can I ask you a quick question before we move on? 5 seems to come up quite a bit. The natural number 5 comes up a lot in healthcare. And I was just going to ask you a question. Why do you think that is? No, seriously, it's like I don't know. It's because I'm thinking as you showed your hand, I'm thinking, well, perhaps it is. I remember Googling it once, and I can't remember whether the there was an explanation which it escapes me at the moment. But for me, it's the number 5 in healthcare seems to be come up quite often. Like, I mean, have you noticed that, or why do you think that is?
Yes, I have. You're reminding me, taking me back quite a few years to when I was, I think, maybe a medical student or maybe an intern, thinking about causes of atrial fibrillation. And I can't remember what they all were now, but it was 5. I do remember that, from, you know, ischemic heart disease to hypertension to thyrotoxicosis, blah, blah, blah. Yeah, I don't know why 5, but it does seem to keep coming up. To me, it speaks of balance. I don't know. It's a great question. And I do like, as I was saying to begin with, I think in that balance, it puts that biomedical intervention in quite a good focus. It also, like, I know I've been fairly passionate, too passionate maybe, about the mind, body, emotional stuff. And some people coming in could feel a bit on the back foot if I'm overemphasizing the mind, body thing. So again, 5 is enough choices to allow people to feel a freedom and a commitment. You know, I want to work on nutrition, not so interested in the other 4. I don't know, but it seems to me to bring in balance. There may be mathematicians think it's a prime number. I was watching a TV program about prime numbers the other day, and it goes a lot beyond 5, but there seems to be some mystical importance of prime numbers. Someone else might have a better answer. I don't know, Pete. It's a great question.
Well, I got into the number 5 because of I used to watch the Gordon Ramsay. You know, he'd go into a restaurant, and the restaurant was failing because he would look on the menu, and there was like 20 odd things on there, and the reason that it was failing because the chef couldn't do all of those 20. But what he would do was trim the menu down to 5. So that the cook, the chef, the cook or whatever, all they had to do was concentrate on 5 things. And then I use that sort of concept when I started adapting the pain toolkit into 5 key skills for people to get, you know, to learn, to get themselves they could do well, like, you know. So, and then but then I started noticing in healthcare a lot, you know, that 5 things like it kept coming up all the time. So. Yeah, interesting.
I don't know. I think 6 for my limited brain triggers me into overwhelm mode.
Yeah,
5,
we want to keep it
I can
simple.
remember 5 things.
Okay, well, thanks very much, Chris. And
Thank you again, Chris.
I'll
That was
move on
great.
now.
Okay.
Thanks for joining us.
Take care, man. Look after yourself. I don't know if you're going to hang around.
Yeah.
Or you're going to go off and do some
Yeah, I
walk.
might. Yeah, I'll hang around for a little longer and
We've
listen
got a
to
Kiwi on
Fraser.
now.
Yeah.
All
Yeah.
right. Thanks again, Chris.
Yeah, thanks very much. And we've got let's say we've got a Kiwi on there. We've got a guy called Fraser Brown that I bumped into. I think it's I'm not sure, Fraser was the year before last.
Yeah, would have been, I think, late 23.
Yeah. And I think we did an interview, and because I think I heard about your story and your podcast, and that the fact we're both bikers, like, so that
Mm,
intrigued me. So I'll get my slides cracking in a minute.
no
Yeah.
problem. Thanks, Pete.
And but I was just going to do a little bit of an intro for watchers and viewers. So Fraser Brown, so he lives in Christchurch, Canterbury, New Zealand. Fraser is a person living with pain and a severe motorcycle accident in '97, and learning from his adversity and persistent pain, he has grown from it, turning into a celebration of living. He has a blog called One Wing Kiwi and a podcast called Screaming in Silence. So just give me a moment to get your slides up.
No problem, Pete. Thank you.
So what I'm going to be doing is, I know I'm going to be working your slides from here, Fraser. So hopefully they're in sequence of what you're going to say. Okay.
No problem at all. I'm sure we can improvise if
Okay.
need be.
Yeah. Okay, mate. Cheers, mate.
Excellent.
Off you
Right,
go.
thanks, everyone. We're sorry, there's nothing more we can do for you. They were 10 of the most impactful words I've heard in the past 27 years of living with chronic pain. Next slide, Pete, when you're ready. Words, though, that didn't upset me nor make me feel abandoned. Instead, they would liberate me and send me on a path of taking charge of my pain management. So October the 19th, 1997, in my hometown of Christchurch, New Zealand, I decided to get my motorcycle out and go for a 2-hour ride around the local hills. However, what I planned on being only a 2-hour journey would turn into a 2-week adventure that would ultimately become a lifelong journey, one that dramatically altered the course of my life. On my way back home, I misjudged my entry speed into a tight corner, causing me to be thrown from my motorcycle and landing on my left shoulder on the metal barrier that went around the outside of the corner. My shoulder impacted one of the support posts, and the force of that tore nerves C5 to T1 out of my spinal cord, resulting in an injury known as a complete traumatic brachial plexus avulsion. I would spend the next 2 weeks in hospital, recovering from this injury. The first few days were the hardest, not only coming to terms with the damage to my body and the severe pain that I was in, but mostly because I wasn't told what had happened to me. So when I was finally informed that I'd damaged my spinal cord, it was a relief. For many, finding out that you'd lost the use of an arm and would spend the rest of your life in severe pain might be devastating, but for me, it really wasn't. When I left hospital 2 weeks after the accident, I was given a bag of medication, 35 pills to be taken each day to help to deal with the pain. My life would soon be consumed by following the regimented schedule of taking them as instructed. Nearly 2 years after my accident, my GP and I had a couple of discussions, which for me were a turning point in my journey. Choices were given and decisions had to be made. And the decision I reached was an easy one. I was quitting the pills, all of them. They were useless anyway, so what did I have to lose? And as it turned out, nothing. Gone was the fear of running out. Gone was the anxiety over forgetting to take them. Gone was the frustration of booking and attending monthly doctor's visits, of going to the pharmacy every 10 days to get my repeat prescriptions. Gone was the focus on the pain and the pills. And to use that term again, I was liberated. During those first 2 years, I discovered that fighting the pain was pointless. It would only tire me both physically and mentally, leaving me weakened for the next inevitable flare, and this couldn't continue. Over time, I taught myself to not fight the pain. Easier said than done, of course. But with the focus on taking my ineffective medication gone, I could put that energy into this new approach. My self-management plan could go into hyperdrive. It had already proven to be the most effective approach I had found to living with persistent pain, and now it was time to see how far I could take it. And where that would end up taking me was further than I could ever imagined. The pain from this type of injury is very intrusive. A constant burning, crushing, stabbing sensation, feelings of the skin being torn away, constant electric shocks. It is both severe and unrelenting. I needed to find a way to be able to calm my brain's response to these sensations. The answer to that for me, ironically, lay in the way I could describe the pain. A hot knife, a clamp crushing my wrist, the skin being torn away, a vice crushing my elbow. If any of this was actually happening, it would of course be necessary to take action to not only remove the danger, but seek treatment. In my case, though, that isn't necessary. I don't have to remove any threat, and I don't need medical attention. I don't need to respond with fight or flight. In my podcast on my journey, Screaming in Silence, I start each episode with an opening that includes the following statement. To the surprise of many, I consider myself one of the luckiest people alive, and I'm thankful for my journey. I feel that too often, when in challenging circumstances, we can focus on what we can't do any longer, what we have lost, and how bad things are for us. Living with constant adversity has instead made me focus on what I can still do, and what I still have, what I have gained, and how good things are for me. This is empowering. It doesn't make me see myself as a victim, as being hard done by. It focuses me on what I can control, which is my reactions, my thoughts, and my actions, and not on what I can't control, such as whether I'm in pain or have a physical impairment. We hear the term acceptance used a lot when facing adversity, that we need to accept what comes our way, and I agree. But for me, I feel that acceptance has a ring of resignation about it, like, oh well, there's nothing I can do, so I guess I'll just have to accept this. So I didn't get to where I am by just acceptance. Instead, I would initially take this concept to embracing my pain and injury. Embracing my pain by not only letting it in, but welcoming it with no judgment, no longer viewing it as an enemy, has made the biggest difference in how my persistent pain affects my life, to the point that I now choose my pain and I choose my injury. The Stoic philosopher Epictetus said, "You can want things to turn out the way you want, or you can want things the way they have turned out." The German philosopher Nietzsche calls this amor fati, the love of one's fate, to not only bear what is necessary, but to love it. Before I learned of this, I had my own saying, which is, when you don't have a choice, your choice is already made. All of us are faced with situations where we have no choice, and we find this uncomfortable. Turning our only option into our choice makes the inevitable much more pleasant for us. Being grounded in the present moment has also been vital for me, to not wish for the past or to be different or fear the future. Another Stoic philosopher, Seneca, has two quotes on this that I strongly resonate with. Firstly, we often suffer more in imagination than we do in reality. And secondly, he who suffers before it is necessary suffers more than is necessary. Marcus Aurelius tells himself to not picture everything bad that could possibly happen, to stick with the situation at hand, and that past and future have no power over him. In the early stages of my journey, while I never looked back, I did have worries of the future. Thoughts like, what if something else happens to me? How will I cope with that and a paralyzed arm and chronic pain? I was suffering before necessary and in imagination, giving the future power over me. I was making my experience worse through letting these thoughts run rampant. Thankfully, I learned quickly to extinguish them. Attitude plays a great role in my self-management plan. Positivity, gratitude, and perspective. I have firsthand seen the difference that these three have made with me, vastly improving the quality of my life through reducing the impact of persistent pain. Not only for me, but for those I've shared my learnings with. I've always maintained that if I can help just one person, then my journey becomes much more worthwhile. With this in mind, I knew I had to get my message out to more people. This is how I started my podcast that I mentioned before, Screaming in Silence. Taking this step has been one of the most rewarding things I've done with my life. With anywhere up to 25% of the population experiencing chronic pain that they have difficulty managing, I knew I could help many more by getting my story out. Through doing this, I've helped and inspired thousands of people. I've received messages of gratitude and still do to this very day from complete strangers, people I otherwise would have never have crossed paths with. I see my journey as a gift I've been lucky to receive and one that I have to share. This exposure has led to great opportunities too. I've been on national news in my home country about my podcast, gaining me a wider audience. I have met people who have opened doors for me to be involved with projects bigger than I ever imagined. Through meeting Pete Moore, I gained an introduction to Bronnie Lennox Thompson, who in turn introduced me to Angie Clerk-Hawke, founder of Our Recovery, a community program helping people to survive and thrive in the face of pain. This introduction led me to be invited to help with 2 pain self-management research programs run by Angie and her team, including people like Toby Newton-John, Himakuva Devon, and many others. This opportunity and and many others would not have come had I not heard those 10 words said to me all those years ago. We're sorry, there's nothing more we can do for you. Thanks, Dr. Ackland, because those words gave me the power to do more for myself. There we go.
Fraser, finish. I think it's the end. Yeah, oh, I think we've got one more slide. Here we go. Give a bit of a
It's
plug there.
the podcast. Yeah.
Yeah, always get that plug, mate.
Thank
Listen,
you.
I think your for me, your journey is. I'm talking to you as another biker now, really, mate, because I've had a lot of friends who've had accidents and stuff like that, and a lot of them just sort of give up bikes and stuff like that. But the fact, I mean, I was just, looking at your photograph there where you go around a bend with one arm, like, steering with one arm. I think, I mean, how the hell was he doing that? I think it's how you change. That's what inspired me. I think what made me curious more. That's why I did an interview with you the other year because you kept using that term about embracing it and stuff like that, and so a lot of people, as I did back in the day, we're trying to go the other way, really. So we'll try to get it fixed and whatever. But what you did there was use the term embracing it, and I thought, what's that? How's he do? What's he going? And it's how you just described it, how you dug in, like, and it's all about changing our perspective, like, sort of. I can't remember the quotes you said there a minute ago, but there's the ones I remember to keep looking at the glass being half full rather than half empty, like.
Yeah, it's so easy, and we all do it. We, often focus on what we can't do any longer, what we've lost, and how bad things are for us. We hear the "why me" attitude, and it's always around why did this bad thing happen to me? No one flips it around to why me, as in how lucky you are still, and why me that I still have the ability to do these things. It's about changing that focus from the negative to the positive, and yeah, I see often in pain communities I'm involved in that a positive attitude, a lot of people push back on that stance. But at the same time, they will be very quick to say that stress and anger and resentment and negative emotions make their pain worse. That being the case, then the opposite must apply. But it's a concept that for a lot of people, I think they are either looking for a cure and not understanding that this isn't about curing your injury or curing your pain. It's about improving the quality of life, which is something that we all want, whether you're in chronic pain or not, we all want to have a better quality of life. Ideally, if I could get the use of my arm back and not be in pain, that'd be fantastic, but that's not going to happen. So I need to embrace what's happened to me and run with it and turn it into something that motivates me and builds me up stronger rather than something that holds me back from doing what I want in life and making me weaker.
Yeah.
I just want to mention this. So Fraser, it's nice to finally meet you almost in person. It was a great story. I mean, that you really are an exemplar of resilience. I just can't, put it any other way. And I just wanted to share actually a fair bit or some similarity between our stories. I was 16 in a near fatal motor vehicle accident, and a lot of the same things as you. But what I found interesting was you were able to come to that place of willingness to, like, okay, let me just move on. Whereas I freely admit, and part of my struggle was it took me a lot longer to get to that point. You were told there was nothing more we can do for you. I was told 3 years after my accident that there's nothing wrong with you and it's all in your head.
Right.
So for me, I needed a validation moment where a healthcare provider at some point finally said, "Hey, your pain is real." I find it really powerful and meaningful that you were able to so quickly look within yourself and say, I can go one of two ways, and I choose the path of positivity. And I think it's a real strength and testament to your resilience. So thank you for sharing.
No problem. No, and yeah, that was something was with me from virtually day one of the accident. I was considered myself lucky that I still had 3 working limbs and I was still walking and talking. I put that down to a little bit of belligerence and ignorance of youth, maybe. I was 22 at the time. I was only 6 years older than you. But, as far as I was concerned, I had no broken bones. I had no lacerations or anything like that. Nothing that, they could heal in hospital. So for me, it was like, okay, I don't have the arm any longer and I've got pain, but I've got a job to go back to and I've got a girlfriend and I've got my family and I've got my life. So, and for me, I just want to share the message that no matter what happens in life, a lot of it boils down to our perspective, what we choose to focus on. And I feel that everything that we encounter in life is an impression, and it's up to us what we make of that impression. We can choose to see it as a good thing or a bad thing. And listening to what Chris was talking about before, with respect to reducing fear and that sense of danger, it's important for me, that I know, despite the pain I'm in and despite the fact that I've lost the use of an arm and I do have a serious injury, there is no danger, there is no threat. So I don't need to take action. So I don't need to, put myself into that fight or flight situation, which just builds anxiety and builds more fear and builds more awareness of suffering and pain. So yeah, reducing the stress and the element of danger and fear has been critical for me in dealing with chronic pain.
I love all that because I think it's a beautiful tie-in to what this evening or day, wherever you are in the world, has been about. As we're talking about, supported self-management or self-management, a lot of things you've talked about that sort of, and it's not toxic positivity, it's positivity of like, hey, I'm alive and I can still do things and I have a life to live, and focusing in on that and knowing that your body isn't in danger. All of those are critically important to those of us who have to self-manage our pain, and being able to find that path to living the best quality of life we can despite the pain, because we can't flip a switch and make it go away. We've all tried maybe once or twice and that switch doesn't exist. So we're like, okay, how do I have this pain with me on this journey, and how do we walk it together and not fight all along the way? And you just have described it, and you came to it so quickly, and I fought and dragged my way through it. So good for you.
Appreciate that. There's something unique about my makeup there. But something, like I say, I see this as a gift that I can share with others. And the messages that I get of gratitude from other people, is immensely rewarding. So it feels good to be a part of this community in a way that I can, offer something.
Well, I appreciate you sharing with us tonight. Thank you.
Thank you.
Has anyone got any questions at all for Fraser before we move on or wrap up for the night?
I don't think you can add to that. I think it's
No,
an incredible message, and it's been an absolute privilege to listen to everybody speak this evening.
Yeah, I think it's a great way. Fraser, I think your presentation has sort of wrapped it up just nice. With your optimism, your stoic.
Appreciate that. Thank you.
Yeah,
first time doing something like this, so a little bit nerve-wracking for me, but I enjoyed it and glad that I could contribute. Thanks.
Oh, it was awesome. It was, like Pete said, it was a great way, we're a little bit bold. Pete and I go out there and say this is the first ever pain supported self-management week. If there's another one out there, we've never heard of it, so we're owning it. We're celebrating the week, and I would suggest that for a really important week that we said it now exists, the conference was, sort of the capstone to this, and your talk was just even the better way to put that final topping on the whole week. So thank you, Fraser. It was great. It was a pleasure.
Thank you for inviting me.
Before we ride off into the sunset, I want to
or sunrise for you guys.
Sunrise, yeah. Just coming up there. It's coming up R5.
Yeah.
Hey, listen. Thanks everybody for watching, or if you're listening on the audio version. This has been a fantastic conference again. The Pain Supported Self-Management Week. That's the first one we've organised, and we're going to do the same again next year. So it's about raising awareness, and it's not just about raising awareness, but also celebrating the what people are doing around the world around pain supported self-management. And we all seem to sometimes work in silos, and I think we need to work a little bit more closer together. It's only going to, if we're going to make a dent in persistent pain matters, then we've got to work a bit more closely. But we tend to be, well, this is what, my little bit, that's my little bit over there, and my work in the pain toolkit. I've never been, the pain toolkit isn't about Pete, it's about everyone. It's everybody. I didn't write it just for me. It's for everybody else to get involved with. And I learned a little saying years ago: to keep it, you got to give it away. So really, all the information that we got to have, keep it rolling. But also, so it's keeping it simple. But all the everybody saying hung around there, and Jerry there with us. I think Chris is still with us. Just to say a few thank yous, really. I want to, for me anyway, thank you to Keith for doing a fantastic job of co-producing, doing his little bit. Gonya for taking the messages. A bit slow on the messages tonight, I think. And don't forget Dave there working in the background, doing his stuff, mate. And without you guys, mate, these are successful because of what you guys do, not me. It's about you what you guys do. Right? It's as simple as that. But anyway, it's great to see. I know, Jerry. I think you said earlier on you have to wear your Superman pajamas or something past your bedtime.
You're going to make last call. You said you could do it. So
yeah.
Oh, we can't hear your audio, Jerry.
I was going to say, if you talk quicker, I can run to the bar real quick and get one drink before they close. That's subtlety.
We don't want to hold you up, brother. So,
and Chris, thanks for sticking around as well. And I think we first met in the States somewhere. I can't remember where was it we met, Chris. I think
it was Florida, wasn't it?
A Florida. I think there was a Disneyland nearby.
Florida, Disneyland, Florida. Yeah.
Yeah.
Orlando, wasn't it?
Orlando, there you go. Yeah, I can never
forget.
Yeah, and it's great to meet you there. Hey, listen, thanks everybody for watching. And what I'm going to do is hand it back over to Keith, because he does a better ending than I'll ever will. Like, he's got the words like more than I've got. So over to you. Wrap it all up, Keith.
All right. Well, thanks, Pete. It's also the middle of the night for you, so early morning. So I just want to echo what Pete said. Thanks to everybody, Grania, Dave. You're the backbone to making sure this thing runs seamlessly. To all the presenters for coming. This was like fantastic. We could have gone on for another 3 hours. I get into these conversations and I don't want to stop. But again, because you all say the things that I love to hear. And sometimes it's okay to be in an echo chamber, because when you're right, damn it. So thank you all for capping off just a beautiful way to cap off the first ever Pain Supported Self-Management Week. We have lots to be proud of. And as Pete and I talked about last week, Pete said, he has these pearls of wisdom that just come out of his mouth. It's a celebration, isn't it? Like, we're celebrating. And I said, yeah, we are. We're celebrating it. So we've celebrated Pain Self-Management Week. We've celebrated the conference. And I celebrate all of you for joining us today and gracing us with your expertise, your knowledge, and your stories. So thank you very much.
All right, there you go then. Well, I'm going to start the process of downloading this. Now I've got to upload it. So I'm going to say adios to everyone and stop the recording. So take care, everyone. Be cool and groovy. Stay safe. Be kind to one another.
Thanks, everyone.
Ciao.
Cheers.
Thank you.
Thank you.
Bye.
Bye now.